to our industry supporters as well, who contribute through the Advancement Office at the University. So we were greatly appreciative of that, and I think we have a number of representatives from industry here this morning. A big shout out to our program manager, Nadia Jabber. Where's Nadia? There's Nadia. Big thanks, Nadia. Basically kind of organizing everything here. And we're also appreciative of our volunteer student, Delphine, who is helping Nadia with this. And we're also thankful to the BMO facility here for being extremely helpful with all of the logistics here this morning. So Albert and I have kind of prepared a few slides, which maybe we'll just kind of give you a little bit of a tour in terms of what's been up, and Albert and I will kind of jointly do this. So welcome to SpineFEST 2023, and this was actually established by Albert a number of years ago. And when we first established the University of Toronto a spine program a number of years ago, we kind of decided to take advantage of many of the activities and infrastructure that was here already to try to bring this together. So this is kind of a nice example of that, and this is kind of a list of our past speakers, and we try to generally kind of balance different disciplines: orthopedics, neurosurgery, basic science, and so on. And Shekhar Kripad has a particular interest in imaging, which will be kind of reflected in some of the talks that we'll be seeing. And a shout out to Professors Tatter and Hall, and we have named this lectureship the Tatter Hall Lectureship, and we're actually privileged to have Charles and Ham here, who will say a few words later, so thanks very much. So, the vision of the University of Toronto Spine Program is around innovation and excellence, and to try to integrate, the amazing clinical expertise here at the University of Toronto with research and teaching and with education, and really trying to integrate the excellence that's here. And as you know, this is a co-leadership model. And Albert and I have collaborated for a number of years, kind of bringing together orthopedics and neurosurgery, but also we integrate other disciplines, as well, chiropractic. So I was just introducing Professor Amendolia to Dean Nodwell, our basic scientists, nursing, other allied health disciplines, etc. And of course, as mentioned, very grateful for Nadia Jabber's amazing coordination as program manager. And as indicated previously, so we're very grateful for the support for the Department of Surgery, as well as the divisions of neurosurgery and orthopedics. Professor Swallow and Jade give their regards. They are otherwise occupied, but I think Professor Ferguson will say a few words in a moment virtually. And we have an amazing faculty at the various TASN units, as well as at the University of Toronto. And this just kind of gives you a little bit of a pictorial kind of representation in this sort of volcano plot, if you will, just kind of where we started, and then kind of where we've been going. And we kind of started very simply, kind of looking at what we might be able to accomplish at an academic mission, trying to bring the units together with combined teaching conferences and research lectureships, and then we've been gradually expanding this. And Albert will talk in a few moments about some very exciting initiatives that are going on through the Royal College level, where the training in spine surgery will be officially recognized by the Royal College, and this will actually be a diploma-based recognition at the Royal College level, and that will actually be unprecedented in the world. So Canada will actually be the first country in the world where spine fellowship is actually formally recognized in this regard, and this will be a cross-Canada initiative through the Canadian Spine Society, but this was really initiated here at the University of Toronto, and a big shout out to Albert Yee and colleagues for taking that forward. And then we've also been increasingly involved in advocacy. And so this just kind of gives you a little bit of a sense of kind of the timeline of where things have been going. This started with the external review in 2007 that essentially said, look, you're world class, but there needs to be greater integration to try to achieve that. And I think that over the last several years, we've been able to really bring the program together quite nicely. So I'm going to hand over to Albert at this point to talk a little bit about the other aspects of our U of T spine program story.
Good morning, everyone, and welcome, and thank you, Michael. So I guess just sort of carrying along with the timeline, we've certainly been through a lot together, and the sort of slide shows the more formal sort of transition into and out of the sort of COVID-19 pandemic. Many thanks to Nadia Jabeur. She was really integral early on as we pivoted fairly quickly, I think, to sort of a all virtual sort of program, but we certainly kept the importance of the academic mission and to continue to deliver some academic content, including education, albeit virtually initially, and then we sort of segued into, I guess, a bit of our sort of hybrid current state at this present time. I certainly vividly recall some of the discussions and the key aspects. Obviously, the clinical piece at the hospitals, many of our clinical faculty, along with many of the fellows, were quite heavily involved with some of the urgent critical care aspects of things during the peak times during the pandemic, and obviously a lot of our scheduled activity had been shunted for a period of time, and we're certainly currently working in earnest at this time to try to deal and manage with the backlog and to continue with providing that care. One of our courses, Dr. Lewis's cadaver course, was actually one of the first courses coming out of the one of the waves of the pandemic, where we sort of were the sort of test case for the university for re-implementing sort of in-person learning. And so we had to go through all the various sort of COVID protocols and testing and safety protocols, and we sort of did a bit of a test run, I think, in terms of developing it as we evolved through the pandemic. We established a new sort of a case-based sort of forum discussion, sort of complement some of our citywide journal clubs that we've had established. In this last year, Dr. David LaBelle at Sick Kids, along with the Sick Kids team, put on a phenomenal pediatric deformity course for our citywide fellows, which was very well received, and we look forward to continuing over the course of the future as well. Many of our institutions have implemented more formal equity, diversity, inclusion, wellness initiatives, which is critically important. And within our program, as well as Michael's mentioned, we've established a bit of an internship volunteer opportunity, and Ms. Nadia Jabeur has been helping us lead and organize that initiative. As Michael's alluded to, the Royal College, we are in process of establishing a diploma in spine surgery. It's going to be a DRCSC designation beyond your sort of specialty FRCSC. Many thanks to Dr. Hall and the Canadian Spine Society. A lot of this has been organized through the fellowship director group and the education committee as part of the CSS. And we established during the course of the pandemic a bit of a national working group through the Royal College to develop materials that are required for this diploma. And in brief, because I recognize some of the fellows around the city that we will be enjoying their sort of graduation ceremony later on this evening, but some of the things to come include the various documents that will be required for this initiative. And essentially there's two documents that will be for the trainees, and one document basically for training programs. And so the portfolio is essentially the sort of dossier that fellows will need to collate during the course of the year or two in training. It's the materials that they'll be submitting to the university and to the college that speaks to the minimum requirements as it relates to the educational experience. It'll leverage some of the data from our sort of case log programs, operative notes, consultation notes. It's multi-source feedback, so supervisor feedback, feedback from other health professionals. The CTR document is really an extension, an update of the national curriculum that we've already developed, and Dr. LaRouche a few years ago organized a pan-national team to develop the curriculum. And that served as a terrific foundation for us because it really fast-tracked our work with the Royal College as it developed this document for the college. And the standards of accreditation is basically the infrastructure that's required at both the university and hospital level to develop and to deliver the sort of diploma content. And it speaks to administrative support at the university level. It speaks to having a diploma fellowship sort of director, so that would be the sort of clinical lead overseeing the fellows around the city. And also speaks to some of the resources at the hospitals. Obviously, you need the faculty expertise, the spine surgeons with the appropriate fellowship level training in both neurosurgery and orthopedics, and some of the core and support services. So beyond sort of spine surgeons, obviously, if you're going to need to be, as an example, performing emergency cases, you need to have an emergency department, you need to have access to those patients, ICU, anesthesiology, interprofessional teams to provide that training. So that's a bit of an insight of what's coming. We anticipate it'll likely be fully implemented in about a year to two. The universities will need around the country to apply to the Royal College for involvement, and we look forward to that. As Nadia's mentioned, Delphine, welcome and thank you for all your help over the last couple months as our sort of inaugural volunteer as part of our internship initiative. In terms of wellness, I'd like to sort of highlight Eric Crawford. He's a clinical associate that we brought on at Sunnybrook. He's a fully trained spine surgeon who went through our training program a few years ago, and he's leading some important work as it relates to wellness for both our residents as well as our fellows within orthopedics, but also going to be sort of helping out with the spine program in and around the city as well. So thank you, Eric. We've trained well over 200 clinical fellows since the formalization of this program now. And this sort of purple diagram of the world shows basically the distribution of our fellows. Typically about half of our fellows come from international backgrounds that come to Toronto for their year or two of fellowship. And the other half are graduated from Canadian residency programs. Congratulations to the 2022-23 fellow cohort. We'll be having the more formal festivities and celebration this evening as part of GTA rounds. And many thanks to all the faculty, to all the participants and audience as it relates to some of the events that we've held this past year. This is just a sampling of some of those events. And Nadia, she's our communications expert and is terrific at organizing our various flyer, our social media, and the organization of our program. Thank you to our judges who helped adjudicate some of the abstracts that we presented today. Many of these faculty have contributed this effort in the service as part of our program council and committees over numerous years now, so we really thank them for all their time and their ongoing strong support of our programmatic efforts. As Michael's mentioned, also our program, apart from strong support from the University Department of Surgery, divisions of neurosurgery and orthopedic surgery, we have a lot of support through industry, through a variety of partners as well that continue to support our educational offerings, and we welcome some of those representatives here today who'll be listening to some of the faculty presentations and our trainee presentations. So we appreciate that. You certainly supported us and continue to support us through thick and thin. All of us having gone through obviously a very significant time over the past several years. So I guess with that in mind at this time, I'd like to invite Dr. Justin Odwell. He's the Vice Dean from the Temerity Faculty of Medicine to provide some introductory remarks. Thank you and welcome.
Thanks very much. It's my second time here. I've been Vice Dean for about 2.5 years now. One of the things I love about the job is, I should say, I'm kind of a U of T lifer. I was a student here in the 1880s, whenever it was, and returned here in 2013, and I truly love this place. And one of the things I love about this job is learning about endeavors like this. And I hear sort of a similar story over and over again. It's interesting reflecting on that introduction, on the sheer volume of really detail-oriented work, everything from training undergraduate students to training graduate students and medical students, organizing conferences, organizing journal clubs, organizing all these educational and translational activities, as well as, of course, everyone's day job, which is saving and improving human lives. It's extraordinary. It's a remarkable collaboration between two disciplines, the orthopedics and the neurosurgery, and the way it expands everything from education at the fundamental level to research to clinical practice and outreach is truly extraordinary. And it's very easy to lose sight of that. We are, as a university and as a broader community, second to none. It's really it's remarkable what we're able to do here through all the collaborative efforts between institutions and individuals. And it's a privilege to be able to experience that and to, when possible, to support it in my current role. So that's really all I have to say. I'll keep it short and sweet, and wish you a wonderful day. Thank you very much.
Thank you, Dean Nodwell. We really appreciate you coming here. Is this on? Let me see. Okay, good. And we have Professor Peter Ferguson, the Chair of Orthopedics, who's online to give some welcoming remarks as well.
Yeah. Thank you, Michael, and thank you, Albert, and good morning, everybody. Can you hear me?
Yes, we can, Peter.
Okay, perfect, thanks. So just want to bring greetings and welcome from the Division of Orthopedic Surgery to all of you today. I guess I've been doing this for about 10 years, giving this welcome at this event, and 10 years ago, I essentially challenged all our other subspecialties in orthopedics to try to emulate this integrated collaborative program that you have, that is the spine program, because I felt that this was certainly the model program that every other subspecialty should strive to replicate. Fast forward 10 years, and you guys are still light years ahead of all the other subspecialties when it comes to your academic productivity, your collaboration, your educational initiatives, and this area of focused competence is yet another example of how you guys are all striving to really push the envelope and continue to improve and be at sort of the forefront and cutting edge of spine education. So I would hope you continue to strive to stay well ahead of the game. I'll continue to prod everybody else to try to play catch up. And I just want to wish you all the best of the day. Wish all the fellows graduating today best of luck in the future, and we look very proudly upon your accomplishments as U of T alumni going forward. Thanks very much.
Thank you, Peter, for your kind remarks, and we appreciate the support from the university and from the divisions of orthopedics and neurosurgery in the Department of Surgery very much. So thank you for bringing greetings. So any program is kind of built on legacy, right? And you stand on the shoulders of giants, and we have two giants here. We have Professors Charles Tatter and Hamilton Hall, for whom we've named the Tatter Hall Lectureship. And Charles and Ham, I wonder whether we could ask you to come on up and do your thing.
Well, thank you, Michael, for this lovely invitation. And Albert, what a wonderful job both of you have done in putting this program together. It's been terrific for Hamilton Hall and myself to witness this development over so many years now, and you've managed to keep it going. The great camaraderie that you gentlemen have displayed, and great acumen in taking this forward now to the Royal College level. It's been a wonderful development. My own experience with Hamilton Hall is a sort of a forerunner of what evolved, because he was able to pass his fellowship in orthopedics because of the tutelage from the rest of us in getting him through. So we go back a long time. It's been a wonderful association, Hammy, and thank you for the friendship and camaraderie. And this is certainly spread around, and Albert and Michael are great examples of how this has worked. And it's not really for our benefit, although we have benefited intellectually and academically from this association, but it's really for the patients. Imagine how much better off the patients are because these two specialties have come together and have been able to find common ground. And the trainees that are now all over the world who have had the benefits of both sides of the spine treatment and academic background, it's been just sensational. So thank you very much. And Ham, please say something.
This is the first time in 4 years that Charles and I have stood up here together. It's been virtual, or one of us wasn't here. We're finally back together again, and I have forgotten, of all the giants I know, Charles is probably the smallest. But I don't mind standing on his shoulders. So I stand behind him every year while he says all the smart things, and I come up at the end and say, me too. The one point I would like to stress, though, about this meeting today and about the whole world at the moment is spine is under attack. We are having trouble finding enough spine surgeons. We're having trouble getting the surgeons we have accredited in hospitals. Orthopedics is beginning to drift away from spine, which is a real issue for the orthopedic side of us. Makes Charles happy, but not me. And I think the important thing for this meeting is how well we have coordinated, how well Albert and what is your name again? have really put this thing together. And they're a model, as Charles has already said, for what can be done in collaboration between the two specialties. So for everybody that's here today enjoying this and what you're going to learn, we welcome you. We welcome our visiting professor. And Charles and I will now go back and sit in the corner as we do and hopefully do it again next year. Michael.
Thank you, Charles and Ham, for being here and for serving as mentors for us and for kind of laying the groundwork on which we've built the program. So at this stage, it gives me a great pleasure to introduce our Tatter Hall lecturer for 2023, Professor Shekhar Kirpad. And Professor Kirpad is the Sanford J. Larson Professor and Chair of Neurosurgery at the Medical College of Wisconsin, and he holds a number of titles at that esteemed institution, including a co-director of the Center for Neurotrauma Research, as well as medical director of the neuroscience unit at Froedtert Health, and he also directs the Spinal Cord Injury Center. And Shekhar is really one of the leading lights in academic neurosurgery and spine surgery. His interests in spinal cord injury and regeneration really, I think, spawned during his time as a postdoctoral fellow at the Karolinska Institute in Stockholm, Sweden, and he's really carried on that work. Over the last number of years, Professor Kripad has done extremely innovative work in the areas of advanced imaging, particularly magnetic resonance imaging, and I think that will serve as the theme for today's keynote lecture. On a personal note, Shekhar is a very dear personal friend and a very dear friend of Toronto. And we're very understanding that you're not able to be with us here in person, but we're very grateful for the wonders of technology that you can at least be with us here in a hybrid sense. So, Professor Kripad, we look forward to your keynote lecture, and if I'm correct, I think you're going to say a few remarks first, and then the lecture, I think, is taped, right? Correct.
Thank you. I hope everyone can hear me.
Yes, we can. Yeah.
Wonderful. I want to reinforce the benefits of hybrid technology. But first, I want to say congratulations to the graduates. The trainees and the learners are what make the reputation of the program grow worldwide, and you come to learning institutions, one of the best in the world here at the University of Toronto, and then really take the knowledge that you gain away with you to disseminate for the benefit of patients, as Dr. Katter just said. So congratulations to the fruition of your hard work is very well deserved. I'm also, I miss being in Toronto. As Dr. Failing said, had a wonderful relationship of over a decade with the University of Toronto Spine Program and Spinal Cord Injury Group. It has been an intellectually stimulating and rewarding relationship. Have been to Toronto many times and hope to be there again in the very near future. So I deeply regret not being able to be there for some family issues, as Dr. Failing stated, but grateful for the hybrid technology that allows me to be there, at least virtually. Just want to reinforce the collaborative nature of your program and how impactful that's been, not only at the level of the University of Toronto, but really worldwide. The spirit of collaboration that you see with the Departments of Orthopedics and Neurosurgery has really been disseminated effectively across several national, international organizations, and all of us in the world of spinal surgery have been beneficiaries of that. The list of speakers that have given the Tatter Hall lectureship really symbolize the effect of the University of Toronto Spine Program at an international level. And finally, it is a very great personal honor for me to be invited as the Tatter Hall visiting professor and lecturer. It is one of the highlights of my career. I just wanted everyone to know that. Both Dr. Tatter and Dr. Failings have been here at the Medical College of Wisconsin for honored guest lectureships and hosted both of them. And this is really quite a significant day in my own career, so I'm deeply personally honored. I really very much appreciate the invitation to be there. And then finally, I want to thank Nadia Jaber. She's been fantastic at organizing all of the aspects of this program, especially as it relates to helping me be able to deliver this lecture virtually. And so, Nadia, thank you very much. So with that, I think we should go ahead to the lecture. Again, deeply honored and very thankful for being invited to it as a Tatter Hall visiting professor. I really very much appreciate the invitation to be in Toronto. I think it is the honor of a lifetime to be asked to be at the Tatter Hall invited lecturer. I'm deeply regretful that I cannot be there in person due to a family matter. but I hope that this presentation will show that I'm there in spirit. I'm very profoundly grateful for the fantastic relationship that the Medical College of Wisconsin has had with the University of Toronto over the last decade, really. The deep and meaningful friendships with Dr. Feelings, and I really again thank Dr. Feelings and Albert Yee for inviting me. And with that, I think I'll go ahead and start my presentation. So I thought it would be fitting to talk about our work in the development of imaging biomarkers in spinal cord injury using magnetic resonance imaging to discuss our approach with translational perspectives and how we adopt a reverse translational approach in our laboratory, working with a rat and mouse model of spinal cord injury with imaging, and then using that as a mechanism to translate findings to patients. First of all, I want to acknowledge our funding sources, our endowments with the Brian Reese Foundation, the Gale Endowment, the Van Wagenen Fellowship of the AANS, which really got me started in the field of spinal cord injury, support from the NIH, from the VA, as well as the Craig Nielsen Foundation. Acknowledgements are also due to the Medical College of Wisconsin Department of Neurosurgery, the Center for Neurotrauma Research, Medical College of Wisconsin Radiology Department, our neighbors across the street, Marquette University, as well as Freighter Radiology. Listed on the right are our various sponsors. I wanted to particularly call out Kajana Satkunendra Raja, who I've highlighted in red, who represents the level of collaboration that we have had between our two institutions. Kajana, having done her graduate and postdoctoral work at the University of Toronto, who's now a fantastic and productive faculty member in our spinal cord injury group, having recently gained an R01 from the NIH, as well as a large VA merit review grant. This is our team. We really have a translational team composed of biomedical engineers, physicists, radiologists, radiation technologists, a variety of graduate students at the master's and PhD level, paired with clinicians where we follow a dyad model at our institution. Being much smaller than the University of Toronto, this model is very useful for us to turn out translationally relevant findings with our using our research platform. The Center for Neurotrauma Research's mission is to really advance the science of neurotrauma centered around brain and spinal cord injury. And as you see here, it is intentionally pairing a variety of basic science departments, the neurosurgery research laboratories, the Medical College of Wisconsin Neuroscience Research Center, the Center for Imaging Research, pairing those in a logical fashion with clinical science departments, with neurosurgery, neurointensive care, neuropsychiatry, trauma surgery, pediatric neurotrauma, which really encompasses the lifespan of neurotrauma care, and then the VA enterprise that we have close to our campus. This is fueled by advanced bioinformatics and technology, a variety of collaborative partners, including the US Department of Transportation, the NIH, the NINDS, the VA, the CDC, academic and industry sponsors, organized sports, including the NCAA and NFL and various foundations, with really the singular aim of clinical translations. That's our aim in order to, whether it's traumatic brain injury research or spinal cord injury research, we aim towards clinical translation so we can show our partners the appropriate ROI for their investment in our enterprise. I want to say a few words. The University of Toronto is probably one of the world's best programs, not probably, it is one of the world's best programs in neurosurgery, a storied legacy in every area of neurosurgery, including spine and especially spine with Dr. Tatter and Dr. Feelings, who are both present in the auditorium today. I thought I might share a little history for those that might not be familiar with the Medical College of Wisconsin about our own history. Our division of neurosurgery was established in 1963 by Dr. Sanford Larson. Sanford Larson is one of the founding members of the joint section of spine and peripheral nerves of the AANS and CNS. Most of you might know that. He was recruited as the first chair as a young person in his 30s in 1963. He grew the program to be one of the strongest at MCW, both academically and financially. Even to this day, we're ranked number 4 in research funding from extramural sources in the entire institution. He made it its own department in 1983, served as chair until 1999. As I said earlier, he was the founding chair of the AANS Spine Section. He was the first president and founder of the Cervical Spine Research Society, and the first to describe the anterior approach to thoracic disc herniations. On the right is his genealogy. Dr. Larson was a very, very incredibly humble man, but this is how his training came about. Harvey Cushing trained Loyal Davis, who was the first chair of neurosurgery at Northwestern University in Chicago, who then trained Sanford Larson, who spawned a number of other fellows, faculty, and chairs, etc. For those that might be interested, Loyal Davis also has a separate history. He was the father to a young lady by the name of Nancy Davis, and Nancy Davis wound up marrying an individual by the name of Ronald Reagan, so she was the first lady of the United States for quite some time. What is our legacy? We have the oldest neurosurgical spine fellowship in North America. The first fellow started in 1982. 52 fellows so far graduated, 53rd and 54th currently in training. The department has given rise to 4 different department chairs that are currently all over the country. I'm one of them. We've had president of the AANS, Dr. Paul McCormick, 1 CNS president, Dr. Chris Wolfla, no less than 6 joint section chairs of the spine section, a NASH president, Greg Shabilsky, over 2,000 spine publications, and key policy and industry leaders. A shout out to my own mentors, Dennis Mayman and Sam Larson, of course, Bob Ratchison at Case Western Reserve, where I did my residency training, John Robertson, who is my skull-based fellowship mentor. Yes, I did do a skull-based fellowship. I thought I was going to be a neuro-oncologist before I went into spine surgery. Trudy Elliott, famous for coining the word chemotherapy and also the inventor of the original chemotherapeutic drugs, for which she won the Nobel Prize in 1989. Daryl Bigner, who is the reason I became a neurosurgeon, and who leads the brain tumor program, established and leads the brain tumor program at Duke University in North Carolina. And Lars Olsson of the Karolinska Institute, who was my postdoctoral mentor during the Van Wagenen Fellowship, who was really instrumental in my getting onto the field of spinal cord injury. With that background, from a personal perspective and from a career perspective, I thought I might just give an introduction as to why we're interested in magnetic resonance imaging as a biomarker for spinal cord injury. These are 2 of my cases, and most of you in the audience are familiar with similar cases. On the left is a 29-year-old male in a rollover motorcycle accident, was quadriplegic in the scene in the ER. After appropriate surgical intervention, stabilization, and decompression, he was really at HJE at 6-month follow-up. On the right is a 24-year-old male medical student who was in a diving accident, also quadriplegic at the scene in the ER, but continued to remain Asia A at 1-year follow-up. And the grayscale differentiation as afforded by these MRIs really doesn't afford the ability for us to be able to predict at the time of injury which one is going to recover and which one will not. And this is really summarized quite nicely in this article in the Journal of Neurosurgery Spine about 5 years ago. So what is a biomarker? A biomarker or biological marker refers to objective indications of medical state observed from outside the patient, which can be measured accurately and reproducibly. To be good, a biomarker should be sensitive, should be specific, simple, reproducible, and inexpensive. Back in 2019, there was a large initiative sponsored by the NIH, primarily by the National Institute of Neurological Disorders and Stroke, as well as the National Center for Medical Rehabilitation Research, partnered with organizations including the American Spinal Injury Association, the Craig Nielsen, the Christopher Reeve Foundation, the North American Spinal Cord Injury Consortium, the Rick Hansen Institute, which is in Canada, the United Spinal Association, and Wings for Life in Austria, to launch a decade for disruption for spinal cord injury, to disrupt traditional barriers and bring about collaborative efforts, such as the one we have at MCW with you all at the University of Toronto to address key research questions in spinal cord injury research. So with that with that statement, what is the current background? Where are we with general utilization of MRI for the acutely injured spinal cord? We published this study sponsored by the AO and authored jointly by folks from MCW, from the University of Toronto, and other collaborative partners in Journal of Neurotrauma in May of 2019. And the purpose of the study was to determine when clinicians from different AO regions around the world obtain or believe in obtaining MRI for the evaluation of patients with spinal cord injury. Almost 6,000 surgeons were in the database. About 560 responses were obtained. It was spread across orthopedic spine surgeons, neurosurgeons, trauma surgeons, and ER physicians. And the questions that assessed the preferred imaging modality that these physicians chose in different scenarios. Essentially, when we analyzed the results, only a third of the physicians felt that MRI was absolutely essential for pre-surgical planning. So as you might imagine, most of that 1/3 resided in North America or other developed countries. Nearly 10% thought it was totally unnecessary, and the remaining thought only if there was a new deficit, new neurological deficit, and only when available, which really renders it quite difficult to actually perform in a variety of patients. There was, as expected, there was very poor utilization in Africa. At least 50% of those surveyed did not feel an MRI was needed for evaluating a spinal cord injury patient. Why is that? Why do people, besides expense and inconvenience and lack of availability, what are the problems with MRI in the acutely injured spinal cord? Or at least what were the initial problems? First of all, following spinal cord injury, conventional MRI techniques, that is T1 and T2 weighted images, are sensitive to edema, hemorrhage, and injury morphology, but they're not predictive of long-term dysfunction, as is shown here. Lots of different signal changes in the spinal cord, but do not necessarily afford themselves for us to be able to predict long-term function. There's very weak, very low evidence that MRI is useful. There's limited prognostic ability because it does not change the management or patient outcomes is the general feeling. In fact, using T1 and T2 sequences, other than the length of the intraparenchymal or intramedullary hematoma, which is well established to portend a poor prognosis, some elegant studies done by Bizan Arabi's group in Maryland, there's really not any other one or combination of findings, although many efforts have been made, elegant efforts, if I may add, including by the University of Toronto group to get a toolbox together, combining MRI and clinical findings that actually are able to predict outcome after a spinal cord injury. It's even worse with diffusion weighted MRI. In animal models, there's strong utility, like in any other thing in science. Very few human studies that actually have been performed. We've done a couple, and I'll go into that in a little bit. And there's very limited applicability in clinical decision-making or in clinical trials. In fact, patient selection is a key problem. There's only really one paper where diffusion MRI accurately predicts, or at least somewhat accurately predicts, one-year neurological outcome. Imaging quality is modest, and this study used offline quantitative analysis. This is a paper from the University of Maryland, Dr. Shanmuganathan, who showed that there was a correlation of the MRI with the in-ski motor score at the time of injury that could predict outcome at 1 year. The clinical reality of this, therefore, is that diffusion MRI or MRI in general is lost in translation because you can't really translate even the laboratory findings to relevant clinical paradigms in patients. There's issues with cord deformation injuries, issues with imaging artifacts, all of which combine. So in summary, the challenges with MRI in spinal cord injury is the small size of the spinal cord. So technical challenges summarized by small size of the spinal cord, prone to motion, and prominent distortion artifacts from tissues in and around the spinal cord. While T2 weighted MRI has high diagnostic sensitivity, there's low pathologic specificity and low prognostic accuracy. So clinical translation with diffusion MRI, it is sensitive to injury, but has not been routinely adopted. Spinal cord blood flow and perfusion monitoring remains an unmet need, and I'll get into that towards the end of this talk. And then post-surgical MRI, often challenged by the presence of metal hardware, which various groups are trying to get around at this point. Perfusion monitoring, i.e. non-invasive monitoring, really is an important piece that I'm going to discuss later on in this talk, and it really mimics or tries to mimic the secondary injury cascade and hemodynamic changes described initially by Dr. Tatter. So what are our strategies for looking at diffusion MRI of the acutely injured spinal cord? So we've really established 4 areas of inquiry. One is to look at acute cord injury assessment. This is led by the group with Matthew Buddy. The work I'm presenting today is largely the result of initially the collaboration with mine and his lab, and now really engineered by Matt's own lab. I'm also going to describe our early work with remote cord imaging. We're also doing work with imaging near hardware, led by Kevin Koch, and then disc degeneration, which I will not get into in this talk. So one of the first things we needed to do to prove the utility of diffusion MRI in spinal cord injury is to see what it looks like in normal, healthy adults. So that was one of the first experiments or studies we undertook. And the idea was to try, as a clinician, we were thinking we need to get an MRI in the currently commercially available MRIs. This is about 15 years ago to about 12 years ago, where we needed to be efficient with getting an MRI with relevant diffusion information with as little inconvenience to patients as possible. So we developed a workflow as a result of that. And then we studied 25 healthy subjects spread across 7 decades of life and looked at DTI metrics in the individual spinal cord funiculi as well as the central gray matter. We examined age-related changes in cervical spinal cord DTI and looked at the effect of signal to noise ratio along the cervical spinal cord at many segments from C1 to T1. What did we find? We were able to differentiate using DTI individual white matter funiculi and central gray matter as shown in these figures on the left side. We also noted that there was a sharp decrease in anisotropy, which is the diffusion tensor imaging index after the age of 55, dramatically reduced anisotropy after the age of 55. And the changes in anisotropy were seen throughout the cervical spinal cord, but were most prominent in the upper cervical spinal cord, as shown here. And the signal to noise ratios appeared to change in a rostral to caudal direction. So in healthy controls, we were able to show that diffusion MRI can differentiate between gray and white matter funiculi throughout the cervical spinal cord, which meant that we could use DTI to study tract-specific spinal cord pathology. And we also showed that the anisotropy in the tissue of the spinal cord changes with age, which suggested it was important to use controls of similar ages when studying disease states, including spinal cord injury as well as degenerative cervical myelopathy. So some findings from remote site diffusion imaging of diffusion MRI of the acutely injured spinal cord. So this again is a very well-known figure generated at the University of Toronto with Dr. Tatter and Dr. Fehling's work. We were trying to we were trying to design MRI scans and measure anisotropy in a portion of the cord that was removed from the zone of injury. So here's the zone of injury on the right side in the lower part, and then we were trying to measure in the upper to mid cervical spinal cord the indices of the diffusion in the spinal cord tissue to see if measuring DTI indices in the cervical spinal cord could predict the severity of a thoracic injury. Indeed, it did. So we were able to show that mean diffusion in the cervical segments was clearly able to differentiate between sham, mild, moderate, and severely injured animals, in this case rats. There were clear white and gray matter differences, and there was a correlation, a linear correlation between the mean diffusivity in the spinal cord and the cervical segments, and these are thoracic injured animals, and the BBB motor score rather. We were also able to derive correlations with spinal somatosensory evoked potentials, looking at the correlation with the diffusion tensor imaging indices, especially fractional anisotropy in the very early and then late, as well as a combination of very early and early peaks in the spinal somatosensory evoked potentials, which respectively correlate with the medial spinal thalamic tract, the lateral spinal thalamic tract, as well as the dorsal column. So there was a clear structural correlation as well as a functional correlation in terms of outcome from BBB score, as well as spinal somatosensory evoked potentials. In fact, the diffusion metrics were found to be altered as far proximal as the brainstem and the cerebral hemispheres, although we tended to lose some clarity at the level of the hemispheres. Not that that would be very helpful anyway, but as long as the tract-specific structure could be followed cephalad, which is up to the brainstem, we were able to tell the differences with the degree of spinal cord injury in the thoracic spinal cord. We were also able to figure out that the cervical DTI metrics could detect hypercellularity as would occur after stem cell grafts were implanted into thoracic spinal cord. We brought forth a model where stem cell transplantations were known to result in significant astrocytosis. This was summarized in a variety of early stem cell studies. And we were able to pick up signals from excess cellularity in the thoracic cord and the cervical segments as well. We were then able to translate this into patients. So again, about 6 years ago, Dr. Vedantam, who's now one of our faculty members, studied 11 patients with cervical spinal cord injury, compared them with 11 controls. All of these patients underwent diffusion imaging of the spinal cord, median duration of 3.5 to plus or minus 1 day after injury. And the diffusion metrics were measured in the high cervical spinal cord as well as the injury zone. And then this was also a secondary outcome in the Riscus and the Asterios trial as well, just as an aside. And as you see here, here's where we measured, and here's where the injury was present. And there was a significant difference in a population-based. If you looked at a pooled data, significantly reduced anisotropy in spinal cord injury patients in each of the lateral, ventral, and dorsal funiculi compared to controls. So in other words, remote diffusion imaging was able to predict injury, the severity of injury in a lower segment of the spinal cord. So with that early background, we've tried to do a number of things to look at more advanced diffusion MRI in the spinal cord as well as perfusion. It turns out there are several paradigms that are similar in cerebral ischemia and spinal cord injury, whether it's the goal, the recommended treatment, acute imaging diagnostics, neuroprotective and neuroregeneration strategies all put together. Even from a histological perspective, there are parallels between acute cerebral ischemia and spinal cord injury, as shown here by axonal injury detected histologically by beating in the brain and the spinal cord. Our goal here really is to try and personalize MRI of the spinal cord so that it can be used to both as a tool for prognosis as well as to monitor recovery, just as it is in the situation with stroke. What are the questions we aim to address? First, with diffusion-weighted MRI, can diffusion-weighted imaging be improved for better reliability in a clinical setting? And in doing so, does it reveal new information that is useful for patient management? Separately, we've done a number of studies looking at perfusion MRI, looking at can spinal cord blood flow be monitored non-invasively, and how exactly does perfusion change after spinal cord injury as measured by MRI imaging. And then finally, just like in stroke, to look at diffusion-perfusion mismatch to determine if advanced MRI produces unique information and can MRI markers be used to detect acute therapy success. So here, if you look at what diffusion actually affords in terms of localizing a lesion in the injured spinal cord, T2-weighted imaging has extensive imaging changes that don't necessarily localize the level of the lesion. Diffusion-weighted imaging is able to make that damage look exactly where it actually has occurred, so more focal appreciation for the extent of damage. The apparent diffusion coefficients and fractional anisotropy also have a much more widespread area of abnormality, indicating that diffusion-weighted imaging is probably the most appropriate study to sort of localize exactly where there's damage in the injured spinal cord. Similar to a situation with a brain mass vasogenic edema, where diffusion-weighted imaging is able to localize the borders of the lesion in a much more facile way than with FLAIR imaging or using apparent diffusion coefficients. So what we've tried to do is to develop a technique called filtered diffusion weighted imaging. We used to call this double diffusion encoding when we first developed it several years ago. And Matt's group really has done a lot of work to try and perfect this technique. And the idea is here on the left, you see injured axons, intact axons in yellow, and CSF and extracellular fluid highlighted by blue. So the first step with doing filtered DWI is to apply a strong field in a perpendicular direction to try and filter out the extracellular edema, to suppress the edema in the CSF. So if you do that, you're now only seeing either the intact or the injured axons, and now you apply a smaller parallel diffusion gradient, and that would allow us to be able to localize the level of injury just like this. So you can see on the top left panel, the T2 weighted imaging shows an indistinct area of injury, as does ADC and regular DTI, but with filtered DWI, you can see in the orange here, a very focal area of injury that can be localized, which can be used for a variety of reasons: prognostication, appropriate therapy institution, what types of modalities of therapy would be useful for these patients, and the list goes on. So essentially, the idea of filtered DWI is to minimize confounding edema so that we can disambiguate healthy and injured axons. So like I said earlier, first applying a perpendicular filter to suppress edema in CSF, a parallel probe to probe axonal, a parallel field rather to probe axonal injury, and when you combine the two, it can measure axonal injury without contamination from edema or CSF. More importantly, in addition to eliminating the main confounding signals of CSF, edema, and other inflammation, filtered DWI has reduced acquisition time, less than 3 minutes, which is very good when you're trying to apply this in patients. You don't have to do an ROI calculation as you would with regular DTI. There's immediate quantification, no post-processing, there's no variance between scanners, and therefore it's clinically viable. In the animal model, filtered DWI shows a stronger relationship with function than diffusion tensor imaging, as is shown here. Diffusion tensor imaging does not separate sham, mild, moderate, and severe animals, whereas DDE has a clear gradient, and therefore this is predictive of acute and chronic locomotor function. There's significant correlations between acute filtered DWI and 90-day BBB, both in terms of function with the 90-day BBB as well as amount of spare tissue. So therefore, there's a significant clarity of spatial injury profile in acute spinal cord injury, whether it's mild, moderate, or severe. These are 9 different animals, different types of injury, and you can see much more clearly the area or zone of injury as measured by filtered diffusion weighted imaging. We also needed to get filtered diffusion data in the sagittal plane, which would be important to compare it with perfusion in overlays with perfusion MRI. And diffusion prepared fast spin echo significantly improved quality and reduced artifacts compared to echoplanar imaging. And so this was really important to be able to, as is shown here, a much more focal area of abnormality, which can then be compared when you get perfusion data and overlay on top of it, as I'll share with you in a little bit. So what are we doing in patients? We're trying to look at whether DDE or filtered DWI can be a marker for acute spinal cord injury severity, as well as can it be prognostic of functional outcome. We're accruing patients with acute cervical spinal cord trauma, getting an MRI within the first 24 hours after injury, obviously comparing DTI and filtered diffusion weighted imaging. We're doing acute neurological assessments as well as outcome assessments at 6 months post-injury, both ASIA and SCIM scores. So the questions that we're asking are, does filtered diffusion weighted imaging, or DDE, predict 6-month outcome alone or in combination with ASIA? What does better, or is it a combination, or is it imaging alone? And specifically, is DDE a better predictor of ASIA conversion than DTI or conventional MRI? That's the study that's being done currently. Again, this is feasible on the conventionally available 1.5 or 3.0 T clinical inpatient scanners. Preliminary results demonstrate unique sensitivity compared to DTI already. We've got about 34 patients that are getting these scans. We've had some trouble accruing patients during COVID, as has happened with a lot of clinical studies, but we're hopeful that we will accrue to the complete desired extent so that we can get the data out. So these are just some images that show that it's feasible to get DDE images in the healthy cervical spinal cord. So switching gears a little bit to perfusion. So this is an unmet need in terms of non-invasive estimates of perfusion. And obviously, the question of perfusion has been extensively studied by Dr. Tatter and Dr. Feelings, as well as more recently by Dr. Brian Kwan, who's done some elegant elegant ultrasound studies to look at perfusion. So his methodology includes placing a probe in order to measure perfusion. And then we're trying to provide an MR surrogate so that this can be measured non-invasively. The considerations will be pseudocontinuous arterial spin labeling, or PCASL as we call it, is quite well applied in the brain. The idea is to label free water in the blood in a certain plane, in the ascending plane, so to understand the arterial anatomy. We then measure mean arterial transit times. Again, with filter diffusion, as with filter diffusion weighted imaging, we try and minimize artifacts and try and reduce motion and pulsation artifacts. So the idea here again is I don't need to talk to this audience about the cervical vascular anatomy and the spinal cord vascular supply, but really one of the key features here is that as in patients, the vertebral arteries are aligned with the spinal cord. In other words, they're parallel with the spinal cord at C6 and above. So labeling a plane at C6 reveals the anterior spinal artery, the radicular artery, and transit time. So essentially, we're able to label blood flow in one or the other vertebral artery in a different color and use that color coding to define vascular territories in a non-invasive manner in the sagittal plane in the spinal cord. So here's an example of how perfusion changes manifest with this type of PCASL imaging. Here's a bilateral moderate injury at C5, a very focal area of abnormality that is shown here compared to control. And we're able to clearly measure the reduction in blood flow as shown here in the bar graph on the right at C5 compared to controls. And that level of blood flow is obviously higher at a more cephalad level in the spinal cord. So you can do two types of PCASL, time-coded and vessel-coded. On the left is the time-coded PCASL. These green arrows point to watershed zones, which are high-risk areas. So this is a non-invasive way of detecting those high-risk areas, the watershed zones that are between segmental branches to the cervical spinal cord. So it captures perfusion dynamics and reveals watershed areas, whereas the vessel-coded PCASL, as I said earlier, can label the left and right vertebral arteries uniquely and therefore captures individualized arterial anatomy and cord perfusion as is shown here. We're able to get qualitative spatial imaging in a way that is much better than what is otherwise currently available. So when you combine diffusion and perfusion between 4 and 48 hours after injury, you see that the T2, the T1, and the diffusion-weighted imaging lesion expands while the perfusion lesion contracts. So spinal cord blood flow actually at 4 hours, turns out if you compare all of these different modalities, the blood flow at 4 hours is probably the best predictor of long-term functional outcome. Obviously, this is a rat experiment. We're going to try and, we're in the process of trying to translate this into patients. So we're trying to do phantom imaging. Technical progress is ongoing. We've got recently awarded Craig Nielsen grant for healthy human studies to look at labeling blood flow in the vertebral arteries and therefore to the spinal cord. And so in summary, what we've shown with our advanced MR studies in the spinal cord with MR imaging is that diffusion MRI is that acute lesion detection is possible in individual animals. In the human, in patients, early results are consistent with preclinical findings. To make a point about this, acute lesion, the accurate size of the lesion is much more feasible with diffusion MRI than with traditional DTI or certainly with conventional MRI techniques. We also tried to show that perfusion MRI in the preclinical setting is feasible. It reveals early subacute spinal cord injury deficits, and human studies have now started. Obviously, we're going to try and continue human translational studies and then look at how acute interventions alter temporal and spatial trajectories as we measure them in a non-invasive way. With that, I'll conclude. Thank you very much for your attention. Go Bucks. Again, I'm so grateful for this honor, and I hope I can be in Toronto for a different reason sometime soon. Thank you.
Thank you, Shekhar, for that wonderful talk, very clearly presented, and I think it really kind of highlights where we're going with advanced imaging to assess spinal cord anatomy and function in health and in disease. So I think we have some time for questions, and would ask if members of the audience wish to ask a question, just come up to the microphone to facilitate the online discussion. Well, we have some experts in MR imaging in the room, but Professor Tatter is going to start things off.
That was a lovely talk, Shekhar. Thank you very much. In the perfusion imaging of the rat spinal cord, can you get data in terms of like quantitative data in terms of milliliters per 100 grams per minute, such as in, the Keedy-Schmidt type of analysis?
Thank you, Dr. Tyler. It's an excellent question. I don't think I actually mentioned that when I was referring to the slide, but the answer is yes. We are able to quantify blood flow based on that individual labeling of each vertebral artery and quantify it in terms of conventional measurements of the extent of blood flow, so milliliters per 100 grams of tissue per minute.
That would be a real breakthrough if you can translate that to humans now.
Absolutely. So that article was published in Journal of Cerebral Blood Flow and Metabolism when we first did the measurement in the rat model. There are going to be some constraints with translating it. We're working through the translational work in patients, but I could not agree with you more. I think that quantification will be essential, especially if we're to use that information to guide active treatment. Now, the other part of the issue is going to be how are we going to get these scans in patients that are obviously very sick, and so in that 4 to 8 hour window, and so I think that's a logistical issue that needs to be worked out. But certainly that's down the line. But pending that logistical issue being worked out, I think it will be critical to get the quantifiable information to help guide treatment.
That sounds terrific. Thank you.
Thank you. Dr. Hardesty.
Yeah, very interesting work. I was interested in the stuff, the markers that you talked about that were track specific. Particularly, I thought that like one of the challenges in like the MR imaging in the spinal cord that I've worked on is the resolution, particularly in tractography, is pretty limited. And I was wondering, how did you go about, like, what do you think how does that play into the measurements? Is it affecting your sensitivity and like the confinement of the I guess delineation of the specific tracks when you're trying to do like track specific biomarkers? And then related to that, do you think there's a role with these I guess higher Tesla or imaging systems like the 7 Tesla, or do you think that like the lower Tesla that have, I guess, different benefits and like could help with this sensitivity that I think remains a problem, or maybe you can comment on that.
Two great questions. I'll take the second question first, which is asking whether field strength of the magnet applied makes a difference in resolution. The answer is yes. I think there's probably a bell curve in terms of where your field strength is optimized in terms of the clarity of the images that are obtained. Our focus, though, has been a little bit different. two-point preference to point to an individual track. But that's an indirect, there's a lot of post-processing involved in that, and it's somewhat subjective, and there are some inaccuracies built into that. This was the entire reason why the group and Matt Buddy, who leads the group, pivoted to this filtered diffusion weighted imaging, because there is no subjective ROI analysis required. So one can focus on removing, I try to think of filtered diffusion weighted imaging as the MR equivalent of digital subtraction angiography. So you take out everything else, every other signal that would potentially confound your results, and simply focus on trying to look at how many axons are intact and how many axons are injured in a certain portion of the spinal cord. Since we already know the general structure of the spinal cord, the inference in terms of what functions might be disrupted, if you can focally evaluate the injury, should be enough for us clinicians to direct appropriate rehabilitation paradigms or regenerative treatment or other kinds of interventions. So the filtered DWI tries to get around the issue of ambiguity that tractography poses.
Yeah, thanks. That's helpful for sure. So I guess are there other questions, or can I ask more?
Sure.
Right, about the filtered approach. So is it that you're filtering the tensors? So you're like isolating the tensors that like go in a specific direction? Is that the idea? Like that's what I understood, or maybe I was confused. The tensors that like point in, I guess, like the caudal rostral direction. Is that the idea?
Yes, absolutely. And so this is where I get into a situation where I'm a clinician and not a physicist by training. But you're in the what you're saying is correct. For details about exactly from the physics perspective, certainly we can connect offline and we can discuss like exactly how we're like in terms of applying the perpendicular high field imaging to eliminate the confounding tissue, the CSF and intracellular fluid, as well as muscle and bone, and the parallel filter that we're applying to just simply focus on the injured and the intact axons. The details, the B values are varied, they go from 0 to 4,000. We can certainly discuss that offline.
Yeah, that's great. Thanks so much.
Shekhar, I had a question about the challenges with assessment of the spinal cord after surgery because of the metallic artifact. And we and you and others have described the use of remote areas of imaging. So for example, using C2 as a surrogate for what's going on in the cervical cord. Can you maybe comment on that? How valid is that, do you think? Is that an approach, do you think, that maybe we can take advantage of?
Thanks, Michael. So that obviously highlights the original path we thought would be most clinically relevant and useful. I think that still continues to be relevant, although I would say at a more gross level. I think the predictability is there because there are transmitted tissue events such as your elegant work with your and Dr. Carter
Thank you. I think on that note, perhaps, maybe one more question from Dr. Amendolia. Yep.
Thank you, Dr. Kripat, for a great talk. Carlo Mendolia. Can you speak to the technology in chronic degenerative cervical myelopathy and how that applies?
Great question. I was hoping to sort of like make comments about myelopathy as well, but I felt after putting the talk together that the principles that we are trying to apply with imaging the injured spinal cord are relevant for myelopathy as well. So it's essentially physics, so to speak, and so. But in terms of the results that we've had so far, so Aditya Vedantam, who I referred to in my postdoc about 10 years ago and has now come back as a faculty member, was just awarded, which I'm very proud of, just awarded an R01 looking at the relationship between some specific clinical tests combined with filter diffusion weighted imaging for cervical myelopathy. So from a MR perspective, the technical applications are similar, although the interpretations are a little bit more nuanced compared to spinal cord injury. Again, it depends on the severity of myelopathy, of course, as you might imagine. But like Dr. Feelings' group had done some years ago with Alan Martin with spinal cord injury, putting together a toolbox, if you will, of combining certain MR findings with clinical studies, to try and establish a predictive algorithm. We're trying to do a similar exercise with cervical myelopathy using filtered DWI as well as certain specific tests that Dr. Vedantam is developing along with our collaborators at Marquette University. So great question. Thank you for asking.
Terrific. And I think on that note, we'll close it out. And Professor Kripat, thank you so much for a fantastic lecture. Shekhar, thank you. And Shekhar, normally at this time we give you a number of gifts, and they're on the table on the side. I don't know if the magic of hybrid technology will allow the camera to point to that, but we'll show you. We have Albert is bringing these up here. Yeah, we have a few things here for you. So, okay, here we go. So we have this for your desk, to add to your desk. The coveted University of Toronto tie, a signed book, and a few other things. So we'll be forwarding that to you as a little a package of and a sign of our appreciation. So thank you very much.
Thank you. The greatest gift is the invitation. So, but I appreciate all of the other symbols, and really this is quite an honor. Thank you for the invitation.
Well, thank you. Okay, well, before we have a break, we are going to now call on a number of our trainees to come up to do what we've referred to as an elevator pitch. And so this is in lieu of the poster session. And I wonder if all of the trainees could perhaps come up here and line up, if that's okay. And then we'll get you coming up. And I think each trainee has a minute and a half.
So I guess this is our 15th SpineFEST, and so we thought we would try something a little bit different this year. And many thanks to Dr. Carrie Wine, who's sort of part of our program council, sort of suggested this idea for us. So instead, and in lieu of our usual sort of poster session, we'll have each speaker provide a 1.5-minute presentation, just sort of highlighting their area of interest, their area of work. And I think it provides an opportunity for folks, perhaps during the coffee break session, to sort of connect with the various presenters to inquire a little bit more about the various projects. Okay, so the first presenter will be a postdoctoral fellow from the Toronto Rehab, Kite, University Health Network, and this will be Dr. Gustavo Balbinot, speaking on cervical transcutaneous spinal cord stimulation elicits motor evoked responses in the forelimb of rats. Many thanks to the judges. So a few of the judges will be and basically the judges will feed back to Drs. Carrie Wine and Dr. Carlo Amendolia to help organize this. And
Yeah.
okay, so we're on a time buzzer here today. So
Can I get my slide on?
terrific. Okay.
Okay, just. All right. Hi, everyone. The gateway to the spinal cord, the dorsal roots, convey information from the periphery to the spinal cord through large diameter afferents. Spinal cord stimulation acts on those fibers to engage spinal cord circuits and promote targeted reorganization. Here at the Feelings Lab, we are optimizing a cervical transcutaneous spinal cord stimulation protocol to be applied in rodents treated with stem cell transplants. We hope that this enhanced form of rehabilitation may promote targeted reorganization of spinal cord circuits. As a first step, we collaborated with clinical scientists at Kite, Toronto Rehab, to obtain recruitment curves from healthy humans. We are now comparing those recruitment curves with spinal cord stimulation between the human and the rodent model. Our preliminary results indicate that our technique can evoke polysynaptic response in rats, similarly to humans. The polysynaptic response is characterized by the post-activation depression. In other words, the reduced amplitude of the second pulse in a double pulse protocol is shown on the right-hand side. As a proof of concept, I implanted electrodes in the motor cortex and delivered stimulation to observe the post-activation depression, upper panels. When I delivered the stimulation through the skin and through the spinal cord, I observed a similar depression. This indicates that our spinal cord stimulation protocol can target the spinal cord through the dorsal roots and can promote targeted reorganization with stem cell transplants. Thank you so much.
The next speaker is actually from my lab. Is Katerina, who's a PhD candidate, and she'll be talking about her stem cell research.
Hello, everyone. So like Dr. Feeling said, my name is Katarzyna Pieczonka, and today I'll be discussing some of the work we've been doing related to promoting the differentiation of neural progenitor cells into oligodendrocytes through the induction of OLIG2 expression. So spinal cord injury leads to the loss of neural cells within the central nervous system, and this leads to impaired signaling. And so neural progenitor cell transplantation aims to replace the lost neurons, oligodendrocytes, as well as astrocytes. However, the majority of the cells tend to differentiate into astrocytes within the injury microenvironment. And so what we aimed to do was to generate a source of inducible oligodendrogenic neural progenitor cells to increase oligodendrocyte differentiation by introducing the OLIG2 transcription factor into neural progenitor cells using the doxycycline inducible promoter. And so we then characterize these cells using a number of in vitro techniques. And so qRT-PCR analysis revealed that there was an increase in several oligodendroglial lineage genes within these cells. Immunocytochemistry further corroborated these results, showing that there was an increase in oligodendroglial differentiation compared to neural progenitor cells. And then finally, bulk RNA sequencing also found similar results. So ultimately, we generated the source of inducible oligodendrogenic neural progenitor cells. Thank you.
Okay, the next presentation will be provided by Leanna Abraham, supervised by Dr. Akins, rat model of mixed osteoblastic osteolytic bone metastasis suggests psoas muscle attenuation and volume loss.
Hi everyone, I'm presenting my project on prostate cancer, which is known to metastasize into the skeleton. Growing evidence suggests that there's a relationship between the bone weakening during this disease and sarcopenia, which is the atrophy of the muscles. Together, this is called osteosarcopenia, and it can severely impact a patient's quality of life. By leveraging the current standard of care for prostate cancer patients involving serial CT imaging, we aim to determine imaging biomarkers related to changes in the psoas muscle to help enable the early detection of prostate cancer. Our approach involves an intracardiac injection of ACE1 prostate cancer cells into nude male rats, which will cause the metastasis into the spine, and we can confirm this with bioluminescence imaging. Segmented out psoas muscles from co-registered MR and CT data reveals that rats with metastases have experienced attenuation of the muscle, and this could potentially be due to fatty infiltration of the muscle, and we can confirm this with oil red O staining of the muscle that could indicate fat infiltration. Additionally, rats with metastases also experience a decrease in muscle volume, which confirms the presence of sarcopenia. Imaging biomarkers related to the volume and attenuation of the muscle can be used to evaluate disease progression and potentially lead to the earlier intervention of osteosarcopenia. Thank you.
Thank you. The next talk will be given by Nayab Punjani, who is a PhD student in our lab.
60% of traumatic spinal cord injuries occur at the cervical level with the most severe sensory motor deficits. And so the only available clinical guideline for the treatment of spinal cord injury is early surgical decompression. However, this does not target the various secondary injury cascades such as neuroinflammation and cytotoxicity, which overall creates an environment that impairs neural regeneration and recovery. And therefore, having a therapeutic that is able to target these secondary injury cascades along with aid in cell survival is key to improving patient autonomy and recovery. Therefore, the goal of my project is to administer a peptide therapeutic drug termed NX-210C, a neuroprotective agent that is able to improve both tissue repair and functional recovery following cervical traumatic spinal cord injury. We use a clip compression contusion model, which aims to mimic bilateral compression contusion crush injuries observed in traumatic spinal cord injury. We administered this at 2 therapeutic time windows, 4 hours and 8 hours post-injury, corresponding to about 12 hours and 24 hours in humans. We saw various improvements in functional recovery, including weight gain, bladder recovery, and trunk balance, along with improvements in tissue preservation, a reduction in cavity size, as well as improvements in neural preservation. Therefore, NX-210C shows immense promise to be acutely administered as a therapeutic drug for improving both tissue repair and functional recovery in cervical traumatic spinal cord injury patients. Thank you.
So I think Dylan Gauthier, speaking on behalf of Priscilla Chan, antegrade and retrograde self-tracing neuroprogenitor cells for mapping transplant integration into endogenous neural network.
Great, okay, thank you. Also sweet, okay, there's the timer. So as everyone here is aware, or many of us here are aware, that neuroprogenitor cells or stem cells are an exciting potential therapeutic approach for tissue regeneration following spinal cord injury. Particularly, neurons derived from NPCs are very important to reestablish synaptic connections across the injury location, therefore reestablishing functional connection above and below that injury site. However, the problem that exists right now is that there's a lack of robust and clear experimental tools to actually identify and quantify the synaptic connections made by neurons derived from NPCs. So this problem has been addressed by Dr. Felling's lab, creating these self-tracing neuroprogenitor cells. And essentially what these cells are is they're genetically engineered cells that have both a retrograde and an antegrade transsynaptic protein that's tagged to fluorescent proteins respectively, which allows for the direct visualization of both neurons downstream and upstream of neurons derived from NPCs. So far, work in the lab has shown in culture, as you can see on my slide here, these cells do indeed differentiate into neurons in culture. They do project axons. They have these nice action potentials that they fire. And now work is going into showing that they are in fact showing and forming functional circuits both in primary culture, and then ultimately this can be used in vivo as a novel tool for investigating therapeutic interventions to enhance stem cell transplantations following injury and disease. Thank you.
Thank you, Dylan. And next speaker is Sydney Brocky, who's a PhD student here at Kremble. And Sydney is examining the role of CX3CR1 in degenerative cervical myelopathy.
Okay, looks like there's some misalignment on my slide, but that's fine. So I am presenting my work today on microglial CX3CR1 signaling in degenerative cervical myelopathy, or DCM. So moderate to severe cases of DCM can be treated with surgical decompression, but we know that functional recovery can often be limited by secondary injury. And in the context of the CNS, resident microglial immune cells modulate neuroinflammatory responses in large part through the fractalkine pathway, or the CX3CR1 receptor pathway. And so this receptor they express on their cell surface, and it affords them direct contact with neurons. And so knowing this, we looked at CX3CR1 regulation in a rodent model of DCM, and we confirmed that microglia upregulate this receptor across the degenerative period, as well as up to 5 weeks post-decompression. So knowing this, we looked at CX3CR1 knockout mouse models of DCM, and we've confirmed that knockouts in wild types degenerate similarly, but following decompression, knockouts experience increased hyperalgesia, as well as worsened astrogliosis and increased neuronal loss. And so this has led us to believe that endogenous microglial inflammatory signaling may actually be a protective strategy following surgery, and has led us to investigate interesting questions about endogenous repair mechanisms and how these can be harnessed post-surgery.
So the next pitch will be provided by Dr. Rajesh Kumar, recognizing spine fellowship training in Canada, an updated literature review of fellowship education, and surgical case list review referencing a national curriculum of procedural competencies.
Thank you very much for this opportunity. Spine fellowship training has become an integral part of training, and even though it's less structurized as compared to residency, even though LaRouche et al., they published a core curriculum with the help of Canadian Spine Society that define the training competencies in terms of cognitive and the procedural competencies. At the same time, Batman et al., they define the high importance in terms of training perspective, even though they were less confident at the end of training the high importance cases. Recent published literature through North American Spine Society, they published even the fellows will get exposed almost 200 to 450 cases every year. But there is some variability in the case coding. Critically, literature has highlighted a key opportunities to increase the diversity of fellowship from the educational perspective, training, as well as supervisor perspective. To date, at the end of April 2022, I was involved in more than 202 cases, out of them most related to degenerative, followed by trauma, metastatic, and then few were related to infections. With this in mind, and considering the work done by Batman, that ideally the remainder of my training should be focused on thoracic, anterior, and lateral oblique procedure. At the same time, Royal College, through the AFC diploma, they formally recognize the fellowship training at accredited centers. And hopefully this will be implemented in 1 to 2 years, and the case logs as well as the useful tool track to the experience, and then they will help us in training. Thank you very much for this opportunity. Thank you.
Thank you very much. The next speaker is Dr. Ahmed Cherry. He's one of our spine fellows here at the Toronto Western. And Ahmed will talk to us about the assessment of changes in opioid utilization 1 year after elective spine surgery. And this is from the CSORN data set.
So thanks everyone for joining us. As Dr. Feelings mentioned, this is a CSORN data set, which is essentially looking at the perioperative use of opiates in our patients. So, you know, the opioid crisis, oh, it's actually the wrong presentation. This my presentation for the afternoon.
Can we go to the pitch from the afternoon? Maybe, I think Dr. Cherry's presenting twice today.
Yeah.
It would be pitch number 11. Can we get that pulled up? Thank you. All right, terrific. We won't count those 30 seconds.
Amazing.
All right.
So we can just start. Perfect. So as I indicated, this is a Canadian Spine Outcome Research Network data study and looking at the perioperative use of opioids for our patients undergoing procedures. So in terms of the opioid and the background behind this, so the opioid crisis has been causing a significant amount of loss of wages both in the US and North America, with up to $5 billion loss of wages in Canada. So what we identified was essentially perioperative patients looking at their demographic data as well as perioperative data to see their opioid use. And the reason being is we found that patients in previous studies, not our own, showed that the use of opiates has a negative prognosticator on patients undergoing surgery. So we identified 5,000 patients who were included in the study. About 50% were male, 50% female. At 1 year, 77% of our patients were not using opioids, which also means that about 23% of our patients were still on opioids. Unfortunately, 60% of our baseline users became non-users, fortunately, but unfortunately about 9% of non-users are now using opioids at 1 year. So what's the problem with this? So obviously the problem is we're now converting patients who are not using opioids preoperatively and are now using opioids postoperatively. There's a significant amount of data that we used, and we were able to identify things like patient-reported outcomes, which would inform us about change in patients' clinical status, which I won't go over to now. But essentially what we're identifying is these are at least variables which we can see in our patients, which will allow us to identify them preoperatively. So most patients are not using opioids postoperatively. 9% are still using, are converted users, and about 23% of patients are still using opioids postoperatively. Thank you.
Okay, terrific. So that wraps up our first pitch session. There'll be one this afternoon as well. Oh, geez.
I think we have two more, yeah.
I apologize. It's my error. Oh, do you want to?
Yeah, sure. Is Rajendra here? Oh, great. Come on up, Rajendra. I think you have two pitches here. So Rajendra is one of our spine fellows who is located at the hospital for sick children. I think it's here, no? But I think these are the afternoon ones here. Yeah, I think so.
Good morning, everyone. I'll be talking on my topic on pedicle screw accuracy placed with assistance with machine vision technology. So pedicle accuracy, and with advancement of the pedicle screws, the success rate for the scoliosis surgery has definitely gone higher. But there are lingering concerns about the pedicle screws. Inaccurate malposition screws has always caused issues with neurological injuries, vascular injuries, visceral injuries, leading as high as 14 to 21% of the complications. So this study was aimed to evaluate the pedicle accuracy, the complications and revision rates associated with the machine vision technology in neuromuscular scoliosis patients. It was a retrospective analysis of the 25 patients done at Sick Kids Hospital. We used ultra-low dose CT scan preoperatively, where the doses is as equal as full spine epilateral x-rays, and postoperatively low dose CT scan used to analyze the pedicle accuracy with the Kurzbein classification. We had analyzed around 687 screws, out of which 320 were inserted by the trainees, like residents and the fellow. We found that the accuracy was as high as 98.5%, and there were no grade 2 or grade 3s. We had one grade 3 which breach with the S2AI screws. So also considering the Brown et al. Previous studies showing that the accuracy with the trainees is less than the staff or the senior surgeons, contrary to that study, we found that the accuracy is the same. Hence, to conclude, with the in good hands, the machine vision technology can give good accuracy and less complication rates. Thank you.
And we look forward to your second elevator pitch.
This is one of the studies, Ewing sarcoma, pediatric spine, operative techniques and outcomes, a case series of 7 patients. Ewing sarcoma as such is a very rare disease with the prevalence of 1 to 3 per million per year cases. The current modality of management varies with chemotherapy, radiotherapy, and surgical management. The aim of this study was to evaluate the local control, the complications and survival rate of the Ewing sarcoma patients in pediatric group with a minimum follow-up of 2 years. There were 7 patients with the retrospective analysis done from 2012 to 2023. There were 3 males and 4 females. The follow-up years were 11 years, of which 3 patients were operated with the anterior approach, while the rest 4 were operated with the anterior, with the just posterior approach. 3 patients were operated with the reconstruction of the sural nerve graft in the lumbar region. In terms of the results, we had 88% of the patients with the disease-free survival, almost 88% of the patients with the no local recurrence. 1 patient deceased because of the Ewing sarcoma. 1 patient had a metastasis, but he had a quite advanced stage at the time of the surgery. Hence, to conclude, with the patients with the Ewing sarcoma, if treated with the tailor-made approach of local treatment with in-block or marginal marginal resection, where the morbidity is higher, it can give good local control as well as survival in these patients. Thank you.
Great. Well, thank you for all of the speakers. Fantastic elevator pitches, beautiful work. So I think at this time we'll take a coffee break and then we'll reconvene at 11:15. Okay, so far so good? Yeah, it's good. So I think we're going to get started a little bit earlier, so at 11:15. So if people could kindly start coming back in and taking your seats. And Professor Carrie Wine, I think, will be chairing the next session.
Just wait a minute as everyone takes their seats. So thanks so much. This session is going to be focused on imaging biomarkers, and we have, I believe, 3 or 4 speakers to come up. And the first of those is Dr. Michael Hardesty, and he's going to speak on AI-enabled image-based treatment planning and quantitative biomarkers for spine metastases and osteosarcopenia.
Thanks, Carrie. And yeah, thanks for the invitation. I'm going to speak about 2 projects where I'm using imaging biomarkers.
One is for spinal metastases patients that are treated with spine SBRT, and another one is in advanced prostate cancer patients who develop osteosarcopenia. The vertebral column is the most frequent site of metastatic involvement of the skeleton, with up to 1/3 of all cancer patients developing tumors in the spine. Breast, lung, and prostate cancer are the most common primary cancers to metastasize to the bone. And due to the high occurrence of these tumors, 5 to 10% of cancer patients will develop neurological compromise. And the goal here is to really understand which ones of these subjects are going to become mechanically unstable and would need mechanical stabilization. Stereotactic body radiotherapy is a patient-specific delivery of high-dose focal radiotherapy. It's effective for the control of tumor locally and for relieving pain. However, there's a significant incidence of vertebral compression fracture following this high-dose radiotherapy, and that's what I'm showing in the figure on the right. The patient received this high-dose focal radiotherapy to T3, T4, and T5, and then you can see on the right the follow-up imaging that shows a fracture and clear kyphotic deformity. And really the goal here is we're trying to better understand which patients this is going to happen to. Currently, the patients are assessed with what's called the Spinal Instability Neoplastic Score. It's the clinical standard of assessment. It involves radiological review of imaging and scoring in 6 components. That also includes pain that's not part of the radiological review. And though it's the standard and commonly used, there's an inconsistent relationship with the score and fracture risk. As such, we're looking to develop sensitive tools that are useful for the prediction of vertebral stability. We're targeting the use of standard of care imaging here. I'm specifically going to target the use of the treatment planning imaging used in SBRT. We want it to be automated and easy to use, and we want to improve the vertebral fracture predictions and outcome predictions that are possible so that we can improve patient outcomes and resource use. To address this need, we've developed automated tools for the prediction of vertebral stability that use deep learning. Our approach uses a novel deep learning architecture that I'm showing here, and it allows us to automate the calculation of SINs and make it quantitative, and also to directly predict fracture risk. We developed this with some clinical data sets. I'm highlighting 2 of the data sets that we've collected at Sunnybrook. One's the result of a research study where we followed patients over a year and got serial imaging, and we had a consistent imaging protocol, and we labeled a bunch of the vertebral bodies as well as the lesions within them. And the larger data set is the patients treated with stereotactic body radiotherapy in the spine at Sunnybrook. This is about 500 patients, 1,500 lesions treated, and we have access to the computer tomography imaging and magnetic resonance imaging that's used in the treatment planning here. And we also have clinical and follow-up data of these patients so we know who went on to fracture. To look a little bit closer at the automated SINS framework, it involves the calculation of several of the SINS components that I'm going to talk more detail about. It also involves segmenting and identifying each vertebrae in the spine as part of the output. So the first SINS element is bone lesion. So we isolate and quantify the lytic involvement and the blastic involvement using a histogram-based approach and show that it agreed with manual contouring of these same lesions. With this tool for lytic involvement, we've shown that patients that had greater than 11.6% tumor involvement were 37 times more likely to fracture. Similarly, by looking at vertebral body collapse, patients that had 20% greater vertebral body collapse ended up being treated for instability, whether bone cement or instrumentation. The next SINS element is spinal alignment. So spinal alignment is a kyphotic or scoliotic deformity, and this is calculated by finding the vertebral body centroids, fitting a spline to it, and evaluating the angle based on the local curvature, as well as isolating the end plate, the vertebral end plates, and calculating the angle between them. The next SINS element is vertebral body collapse. Essentially, we use the adjacent vertebrae vertebral body volumes to tell us to help us estimate the collapse of the target vertebrae. And we identify the vertebrae using the model that I spoke about earlier, and then we segment the vertebral bodies using a segmenter. And we've shown that this agrees moderately with manual assessments done during SIN scoring. The next element is posterior lateral involvement, where we're actually training a similar network. This is some ongoing work that I'm working on with some of the spine fellows at Sunnybrook. We're looking at posterior lateral involvement, so that's involvement of the pedicle, so metastatic involvement of the pedicles, the costovertebral joints, and the facet joints. And we're looking at detecting it in CT as well as in MR, which the radiation oncologists prefer. Highlighting a little bit of our work on the MR-CT fusion that we're doing. We developed some novel techniques that use deep learning to do this fusion that is a problem that we've had problems in the spine. And we've shown that it works well in our spine data as well as in some international challenge data sets. And we have sub-voxel accuracy with this fusion. So this is really what we want is an automated SINS framework that's going to help with fracture risk prediction. And we've looked at combining the features, the quantitative features that we've calculated in a preliminary data set, like a subset of our data set. And we've shown that we've improved sensitivity 3 times over SINS alone in our data set. So ultimately, we have a system for automated and quantitative assessment of metastatic spinal stability. We're looking to integrate this into treatment planning tools that are based on these imaging biomarkers. We have an auto-SINS that we can calculate that's also automated as well as quantifiable and interpretable, which we think is important for adoption and deployment. We've shown that we can improve fracture risk performance. We've also done some work on stability assessments. And ultimately, this is about making fracture risk predictions. So the impact of this work is it allows personalized treatments through quantification of imaging. We're looking to develop a clinical decision support tool and to affect the next generation of clinical guidelines for managing these patients. We want to bake in these quantified elements into future guidance. This, we think, can improve patient quality of life. As part of this work, we created the largest spine SBRT data set that includes both patient and imaging data. That's really crucial to this work. And future work, we're looking to do a prospective trial and pursuing licensing with medical software companies that can really translate this work out of the lab and into the clinic. So in addition to metastatic disease in the spine, many patients with cancer also develop other musculoskeletal issues that can also benefit from the assessment with imaging biomarkers. Here I'm going to talk about my work on osteosarcopenia and advanced prostate cancer. So osteosarcopenia is the co-occurrence of osteoporosis and sarcopenia, and it occurs in about 34% of prostate cancer patients. Prostate cancer patients treated with androgen deprivation therapy have a significant risk of developing both osteopenia and sarcopenia, and the period of active disease when they're receiving this androgen deprivation therapy can have an irreversible impact on their musculoskeletal health and really affect their quality of life and their ability to tolerate different treatments. So it's a potent risk factor for poor outcomes and quality of life. So better predictions can help us understand osteosarcopenia and improve patient outcomes and make treatments more effective. So we have a project that's funded by CIHR to look at osteosarcopenia biomarkers in this advanced prostate cancer population. It's both a retrospective clinical study that's multi-center and also a preclinical study. Leanna, one of my students, spoke about it earlier, the preclinical work that we're doing. And we're really looking at imaging biomarkers in serial imaging is the goal, to look at can we detect who's going to develop osteosarcopenia earlier, and can we also understand better how it interacts with the treatments and the disease progression that they receive. We're looking at the same imaging biomarkers in the preclinical study and in this metastatic model of prostate cancer that metastasizes to the spine and causes osteosarcopenia. So I, with my team, have developed a computer vision pipeline for assessing osteosarcopenia and CT abdominal imaging. Here, we are focusing on 3D assessment because of the increased sensitivity that it allows us. So what comes in is abdominal CT imaging that's standard of care that the patients are getting as part of their care to monitor their disease, and out come these quantitative imaging biomarkers of osteosarcopenia. We've looked at how well it agrees, how well it performs, and so we've looked at how well it agrees in 3D by comparing it to manual assessments of how well do we isolate the psoas muscle, and we've also looked at how well does it agree with the current standard, which is 2D assessments, and we're particularly interested in changes. And so we've showed modest agreement with the current standard, which is 2D assessments, which would be expected because of the inherent differences in 2D and 3D. Oops. In our preliminary preclinical analysis, we found that osteosarcopenia was strongly correlated with tumor burden, and also that changes in muscle quality and muscle volume were both related to bone mineral density. So the impact of this work is we have novel quantitative imaging biomarkers for advanced prostate cancer that use standard of care imaging, and so it allows minimally invasive monitoring. We will look at predicting outcomes and allowing us to personalize treatments for these patients. And then these preclinical studies will allow us to deal with any confounding that might be present in the retrospective analysis, as well as tie our imaging biomarkers to physical changes. In future work, we're going to focus much more on the temporal progression aspect that is really important for this, the sensitivity that we need for this need. To summarize, I've developed some quantitative imaging biomarkers for the spine and musculoskeletal health. They can aid in computer-aided decision-making applications. And then this can also give us new insights about musculoskeletal disease and treatments. I've talked about vertebral compression fracture predictions and osteosarcopenia progression. And I'm looking to translate this technology through the clinical and commercial partnerships. I'd like to thank funding and the students that did the work and the collaborators that made it possible.
So we have a little time for questions from the audience. So I'll start off with a question. When you're thinking about spine and psoas muscle segmentation and vertebral body segmentation, are there other applications that we can think of beyond prostate cancer? So other spinal pathologies where this might be of use, looking at side-to-side differences or other pathologies that we might apply this same type of pipeline?
Okay, so there's some work that we're doing with in this osteosarcopenia project to look at outcomes following surgery. So there's an interest in can we say so osteosarcopenia is a little bit similar to this concept of frailty, and frailty has been related to surgical outcomes, and we're looking at surgical outcomes in emergent fracture with our collaborators in Ireland. They're interested in better predicting surgical outcomes using these osteosarcopenia biomarkers. But I'd be happy to take any suggestions from the surgeons that I'm sure would know much better.
Thanks so much, Michael. I guess as you're thinking about translating this towards the clinic and, when we get together in a multidisciplinary rounds and go over these sort of patients, how long would these sort of algorithms and things to sort of take to calculate if we're using it as part of the clinical decision-making tool with the technique?
The absolute most complicated algorithm would take less than 30 seconds to calculate. It's a lot of work on the training side because essentially you're getting it to learn all these weights, but once you figured out what all the weights are, it's very, very quick to do the computation. As long as we have the right imaging, they'd all be, the most complicated one would be 30 seconds.
Hi, absolutely great work with the SINS prediction tool. I've got a question in terms of, because the SINS is originally not developed as a predictive tool, but really as a referral tool. So are you also looking outside in the algorithm to other factors or the combination of lesions, because the SINS is really based on only calculating a score for one single lesion and not taking into account that there are multiple lesions in the spine? Are you looking into that as well?
Okay, so yeah, the question is about, are we looking at other factors and other lesions in the cord? So we have done some work to look at that question specifically in our clinical data set. So in the clinical data set we do have information about how many lesions the patient has, and we did find that in some of our modeling that I didn't present because we aren't calculating that from the imaging directly. It was from our anyway, it was a clinical piece of information. We did find that it was significant at telling us about who's going to proceed to fracture. And yeah, I acknowledge that, yeah, SINS isn't developed as a fracture prediction, but I think it is getting used in this way, and we do have this patient population that is fracturing, so that's, I guess, what motivated us to develop this tool. And so yes, the number of lesions is predictive. It's something that we could look at when we have all the tools together, because we'd be able to identify the lesions, quantify each lesion. I guess I would want more input on the clinical need side, and I'm happy to talk more about that. We had focused on one lesion because the rad-oncs are like, oh, I want to blast this lesion, right? So then, okay, can I blast it? Is kind of the question. And so we had focused really on the one, that's how we like structured all the work that we were doing. That's what motivated us in that way. But I understand, yeah, a patient's a whole patient. They're more than just one lesion. Yeah.
Thank you so much.
Thank you. Okay. So our next speaker this morning is going to be Dr. Mohammed Ali Akbar, and he's going to speak on clinical utility of multiparametric quantitative MRI in degenerative cervical myelopathy. So let me.
It's not showing up.
Okay, so I'm going to let you guys take care of that.
So just gonna start from that side. Appreciate it. I think he has to go fix it.
He's what?
I think he's asked to load it from inside.
Sorry for the delay.
My apologies. All right. Hello, everyone. My name is Mohammed Ali Akbar. I'm a PhD student in Dr. Phelan's lab, and I'm the current chief resident at St. Michael's Hospital for neurosurgery. So this is just part of my thesis work. Talking about the clinical utility of multiparametric quantitative MRI in degenerative cervical myelopathy and by extension to spinal cord injury. So the main knowledge gap for DCM, as a lot of people here would know, is the natural history of DCM, which is quite variable, and how we can predict deterioration in patients, specifically mild DCM patients. Now, this study kind of implements on all DCM patients, but mild DCM has been one of our main focuses. But the question is always, how do you measure deterioration? It can be through objective measures, but as many of you who have seen DCM patients in clinic, these deteriorations or their clinical exam might not change, but they may feel different. So there's a lot of subjective functional components to deterioration and outcome measurment. So for the sake of this study, we talked about deterioration and how we can have a overarching marker of deterioration, and one of the factors is actually surgery itself. So the decision to undergo surgery is a combination of discussions between clinician and patient, and some factors are involved where the patient decides that I want to undergo surgery, or the clinician recommends that maybe now is the time point that surgery should be recommended. So surgery as a surrogate has been used previously by Oshima et al. In one of their studies. So we decided to give it a try and use surgery as a surrogate marker for deterioration in patients who are being managed non-operatively with DCM. So why we're trying to look for predictors of deterioration is because we don't have very good predictors currently, especially with respect to imaging. And as Dr. Kirpad had previously mentioned, that conventional MRI imaging, including T1 and T2 weighted signal intensity changes in the cord, are not very predictive, or they might be sensitive but not very specific to pathologies, and they can't be relied on. Other predictors that have been reviewed in large meta-analysis or systematic reviews has been radiculopathy and electrophysiological changes, but not everyone undergoes electrophysiological studies with DCM. So the thing that we're investigating is multi-parametric quantitative MRI. And why multi-parametric MRI as opposed to conventional MRI is just these two images. So images of two patients with DCM and with single level disease and spinal cord deformation at different levels, but to similar extents. But one patient's MJOA score is quite different from the others. One's is 10 and the other one's is 17, and this is the Modified Japanese Orthopedic Association score. From 0 to 18, 18 being perfect, and 0 or 3 being quite debilitated. So conventional MRI imaging, not very useful in predicting how patients are going to do. So why quantitative MRI? Quantitative MRI is a collection of techniques where you can actually get intrinsic values in the normal tissue that are intrinsic to its physiological purpose and can be quantified, and there's normative values that can be compared. Some examples of quantitative MRI imaging is diffusion-weighted imaging, magnetization transfer imaging, MR spectroscopy, perfusion imaging, as Dr. Kripat had mentioned, volumetric imaging. So these are all examples, and we've implemented some of these into our protocol. We started off with degenerative cervical myelopathy patients consecutively recruited in the clinic at Toronto Western Hospital. And all of these patients were initially managed non-operatively for multitude of reasons, and these include severe and moderate as well as mild DCM patients. All of these patients got a baseline quantitative MRI scan, which we will talk about shortly, and as well as a clinical assessment. And then over the year, they had follow-up at various time points in the clinic, but also on the research side. So at 1 year, we followed them up, and during this time, any patient that had deterioration and change in their MJOA, on their exam, on their imaging, or subjective change, and the decision was made to undergo surgery, they were moved into the surgical group, and the others remain in the continued non-operative management group. Our MRI protocol is a 30 to 35-minute protocol, and that has been the main objective, is to make this as clinically translatable as possible. That includes T2-weighted anatomical imaging, T2 star-weighted imaging, or GRE, which we usually see in neurosurgery, magnetization transfer imaging, and diffusion tensor imaging. And the metrics that we extracted from them, you can extract various different kind of metrics, but these are the metrics that we used. So cross-sectional area from the anatomical imaging, the T2 star white matter to gray matter ratio, which has been, sorry, I don't know why it's moving faster than I am. The T2 star white matter to gray matter ratio, which has been defined by Alan Martin, my predecessor in the lab, as a surrogate marker for demyelination, and has been used in our DCM studies. And then magnetization transfer ratio, which again is a surrogate marker for demyelination. And finally, fractional anisotropy as an overall surrogate for axonal injury. So we measured these 4 metrics at 2 levels, so at the most compressed level in the spinal cord, as well as the rostral to the injury. And the rostral to the injury is our attempt to translate this to spinal cord injury patients where you have metallic artifact, and to be able to compare pre- and post-op imaging for both spinal cord injury and DCM patients. We did our analysis in the spinal cord toolbox, which has been developed by our collaborators in Montreal in Polytechnique. And using spinal cord toolbox, we can do template-based analysis and find track-specific changes in these metrics. So in total, we had 58 patients for this study. 29 ended up being in the operative group and 29 in the non-operative group. As you can see, they're somewhat comparable. The MJOA, you might note that the mild, in the non-operative group, there are obviously more mild patients, which is intuitive. So and ideally, we would have large enough data set of just mild patients, and I think that's what we're aiming towards. But in this study, we had a combination of patients. And you can see on the left side, the operative group has a distinct quantitative MRI profile. And two of them are statistically significant. The other two are trending towards significance in univariate analysis. And that includes the cross-sectional area of the cord at the rostral level and the most compressed level, as well as the magnetization transfer ratio. The fractional anisotropy did not reach significance on univariate analysis, but in multivariate, as we will see, it does show significance. The mean follow-up for these patients was about 14 months. So our algorithm, which was just a logistic regression model, was able to predict with 81% or 81.6% accuracy, so that's the C index, which patients ended up being in the surgical group and which patients are going to end up in the non-operative group. And this is without any clinical data, no age, just basically quantitative MRI profile. The algorithm was able to predict with 81% accuracy. It is so the Somers DXY and Breyer scores, I put them on there to give an idea of how reliable the model is, and how good of a prediction it's making. So the Somers DXY is a discrimination ability of the model, where 0 means it's making random predictions and it's just getting lucky, and 1 would mean it's making perfect predictions. So it's somewhere in the middle. And the Breyer score is the reliability of the model, 0 being perfectly reliable and 1 being completely not reliable. And then we did a bootstrap analysis with 100 repetitions to calibrate the model itself, and you can see it fits along the diagonal quite well. It does over-predict at higher observed probabilities, so if you have severe compression, it over-predicts the likelihood that you're going to be in the operative group, which again is somewhat intuitive, but a perfect model will be right along that line. So in conclusion, just from this small analysis, we can see that baseline quantitative MRI does show distinct differences between patients who will require surgery or will likely deteriorate to require surgery. And then there is a distinct quantitative MRI profile for these patients that could be potentially used as reclassifying our myelopathy patients through a series of different images that reflect neurological injury rather than just symptoms in patients. So that is work that we're hoping to further, and I think the next steps would be to increase our numbers of just mild DCM patients to be able to see if there's any distinct changes between patients within that mild population who will require surgery versus who will remain stable. And the other thing that's not included in here is just the multi-parametric approach. I think with neuroimaging, especially in the spine, focusing on one modality, I think it's the limiting factor because of limitations in imaging and the small cross-sectional area of the spinal cord. I think the approach of using multiple modalities in a clinically relevant and translatable model where you have a 30-minute protocol that you can kind of implement quickly and easily across vendors is the key to increasing our knowledge in this area. With that, I would like to obviously thank my supervisor, Dr. Failings, and Alan Martin, my predecessor, who's been a tremendous help, and the rest of the Failings Lab. Thank you, guys.
Endpoint. And I think that your model may actually be better than what it is. And the reason I say that is in the Canadian healthcare system where resources may somewhat be underutilized, I see patients that if I saw them 6 months before, a year before, I say, I would have, of course, offered you surgery back then, versus some patients that come in early and you're scanning. So in order to refine, to have a better data set, is there a more objective way to decide other than surgeon decision to proceed with surgery, or is that just the best we have?
No, I think we can do individual things like individual markers. So in the lab, we measured their gait. We have like objective measures. MJOA so far is like probably the best one to see change. But I think if you do a detailed clinical exam and like by muscle group or electrophysiological changes, which is another study that is happening, I think changes in those are a little bit more objective than again surgical decision making.
So you're using EMG then, or?
Yeah, CHEPS and so that's one of the other studies, but that was not done on these patients.
No, very cool.
Yeah, yeah.
Congratulations.
Oh, sure. From online, we have a question. Can you ask? You can unmute and ask your question.
Sure, thank you. This is Shaker Prabhat. I think this is fantastic.
Thank you,
Very
Dr.
nice presentation. I just have a couple of comments. With respect to if you added, and you may have answered this already, but if you added the clinical exam findings, how much did it improve your surgical predictability rate over and above the 81%, which was just based on the imaging data?
Well, we haven't done that analysis yet, but I suspect it would improve.
Okay.
Yeah.
And then the second question, or it's really a comment, and you made a very good case for multiparametric imaging, several different modalities, while keeping focus on minimizing patients' times spent under the scanner, and the validity of combining 2 or 3 different techniques at generating a higher predictability in terms of what's the output. I think in a lot of ways this represents a collaboration opportunity because it may be a combination of the quantitative studies that you mentioned, along with some of the things we're doing and others are doing, for example, might represent a good longitudinal effort going forward in terms of which combination would be the most ideal to get that predictability number closer to 100%. So I think it represents a future significant collaborative opportunity based on the points you made. So excellent talk.
Thank you, Dr. Brown. I agree. It's a completely novel approach to imaging, and I think there's not a lot of people, apart from Dr. Failings and yourself, who are doing this. So.
Thank you so much.
Oh,
go ahead.
The other comment was also sort of as I'm thinking about this, we were all engaged by Dr. Gogawala in a very important effort to sort of like in patients where there's equipoise to decide between ventral or dorsal approaches to surgery. Would it be nice if we were able to develop an algorithm based on this quantifiable imaging technique, the MRI, if that would be a sufficient, if that could be a significant adjunct in making that decision? Because at the end of the day, I know that there's studies being done about like which of the 15 referees chose what approach in those patients, and we're finding out that some people were instinctively better at predicting which was the correct surgical approach than others, which is understandable based on experience and so forth. But having a quantifiable metric or derived from a variety of different sources would put objectivity and therefore more translatable to future generations. So
yeah, agreed.
All right. Thank you so much.
Okay, so our next speaker is going to be Dr. James Hong, Advances in High-Resolution Sonography of the Injured Spinal Cord.
Oh, I see. This one. Okay.
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 All right. I'd like to thank the organizers, Dr. Failings and Dr. E, for giving me the opportunity to speak today.
Today's talk is really going to be focused on the application of ultrasound on preclinical models of spinal cord injury. It'll be kind of a brief history of ultrasound in this particular field, and then an outline of some of the work that we've done to advance it, and then an overview of the current state of the art and kind of future directions for this application. So just a brief primer on ultrasound and photoacoustic imaging. So ultrasound is the application of high-frequency sound waves that travel from a transducer and bounce back from a target, which is usually red blood cells or other tissues. And this then proceeds to create an image that's depicted in B mode or brightness mode. That's black and white and grayscale. In terms of photoacoustic imaging, it is the combination of ultrasound as well as laser-induced photoacoustic signals. This uses short pulse laser waves, which are then absorbed by tissues and again bounce back to create an image. And the application of power Doppler uses the concept of the Doppler effect, which bounces off sound waves when there's movement, and it's typically what's used to measure blood vasculature, and it's good for the presence and absence of vasculature in the area. And unlike power Doppler, it doesn't really tell you anything about direction or the velocity of flow, but it's good for telling you the presence and absence of low velocity vessels. And it's usually a color overlaid on top of the ultrasound B mode image. So when you look back at the first in vivo use of ultrasound inside the field, we could look back to this paper that dates back to 1995, which used color Doppler imaging and spectral analysis in a canine model of spinal cord injury, and this was a weight drop model. And they performed a laminectomy that you could see in the thoracic cord, outlined by the red line, and you can see that there's an acoustic window that kind of goes down and allows you to see a portion of the spinal cord over here, and you can clearly see the central canal and then the dorsal and ventral aspects of the dura of the spinal cord. When we looked at their Doppler waveforms, they're able to see and look at the flow in centimeters per second and kind of look at systolic and diastolic flow as well using Doppler waveforms. And the next paper that kind of went and did ultrasound inside a preclinical model is this paper from Brian Kwan's lab. And they looked at an application of ultrasound in a large animal model, a porcine model of spinal cord injury. And what they were able to do was exactly the same thing. They were able to create a larger acoustic window by performing a multi-level laminectomy in the animal. And they're able to, again, see the dura as well as the central canal and also the subarachnoid spaces. And their goal in this particular paper was to analyze the changes in the gross morphology of the spinal cord using ultrasound in a non-invasive kind of way. And what they were able to do is show that when they do a moderate impact versus a high impact kind of injury, that there is a gradual swelling of the spinal cord leading to reduced subarachnoid spaces. And there's a rapid swelling of the spinal cord as well after a more high impact injuries. And you could kind of see that the imaging of the dura and the pia is interrupted after injury and the central canal becomes non-visible. So some of the conclusions from the study is that you're capable of detecting all of these gross morphological changes using ultrasound, and that the benefits of this extradural surgical decompression may be negated by subsequent swelling of the spinal cord. And so it leads to kind of early interventions, studies into early interventions to reduce swelling and the importance of those kind of studies. The kind of next studies went on to better characterize the vascular changes after spinal cord injury, and to do this they moved away from using Doppler imaging due to the inability to really get a really good resolution from that image, and they moved towards contrast-enhanced ultrasonography, which is abbreviated as CEUS, to quantify changes in the blood flow. And this was work done by Mark Soberand, who ended up doing some work at our lab as well later on. So in this particular setup, they stereotactically mounted a rat in this particular case to a stereotactic frame, and they stabilized the cord in the lumbar area with a surgical instrument, and then they again performed pre-injury sonography as well as post-injury sonography, and they also did low-frequency harmonic mode analysis to visualize the microbubbles that were injected into the animal as a contrast agent. And when you do this, you can see in the B mode, again, you can see the entire cord during, in the acoustics window, and you can see the central canal, and you can see the disruption of the central canal after injury. And in the low frequency mode, you'll be able to see all of the contrast agent that's moving throughout the cord. And you can see that after injury, there's disruption of the contrast agent in this area here. So to further analyze the blood flow changes, he did various regions of interest to see the flow of the contrast agent from administration and kind of ingress and egress. And through this, he was able to quantify the blood flow changes in the different regions of interest. And you can see that after injury, there is a disruption to the blood flow near the injury epicenter over here. And this blood flow is impeded, and this impediment goes down and gets worse throughout the trajectory of spinal cord injury. So some of the conclusions from this study was that you could use contrast-enhanced imaging to quantify blood flow changes in vivo, and you could then combine that with B mode and be able to also quantify the degree of hemorrhage by analyzing the area that's been disrupted in the central canal, and you can also kind of quantify ischemia after injury and see that it worsens over time after spinal cord injury. So we then did some work, Sarah Figley in our lab did some work looking at non-invasively doing this over a longitudinal time span. So they created a spinal cord window chamber for in vivo imaging and combined it also with photoacoustic applications to look at oxygenation and O2 saturation levels. So using this, they, after performing a laminectomy, there's an acoustic window that's formed, and they're able to perform non-invasive ultrasonography of the cord. And you can see the clear B mode over here, overlaid with power Doppler imaging. And over here, there's the photoacoustic imaging overlaid on top of the B mode. And you can kind of see the, in this cross-sectional image, the perfusion and the oxygenation status of the posterior spinal vein. And they did a series of experiments to show that this was indeed accurate. You're able to have the animal breathe 100% oxygen and then go through a period of time inhaling only 7% oxygen, and you can see the oxygen saturation percentage drops down, and then after restoration to 100% oxygen, it elevates again. So some of the findings from this study was that you could perform longitudinal in vivo ultrasound imaging through a window without sacrificing the animal, and you can use photoacoustic imaging to depict O2 saturation through hemoglobin. So this led to some of the work that Mark did in our lab, which was the use of high frequency ultrasound, and we called it kind of very high resolution ultrasound imaging. And this allowed us to quantify, without sacrificing the animal, vascular disruption as well as gross morphological changes to the spinal cord. So the previous frequencies that were used in those previous studies were typically 10 to 12 megahertz, but the small diameter of the rodent spinal cord, and usually around 3 to 4 millimeters, limited the resolution of the imaging. So in order to get a better resolution, several devices, one which we have here at the hospital from Visual Sonics, was capable of performing high-frequency ultrasounds at 40 to 55 megahertz, which are designed to image smaller animals. And it allows us to get a spatial resolution around 30 microns per pixel. So the setup was very similar to how we set up the initial studies in the other experiments. So we mounted the animal on a stereotactic frame. And this time, in order to generate sagittal slices of the spinal cord for later 3D reconstruction, we had this probe mounted to a motorized driver that could drive kind of sagittal acquisitions of ultrasound on the spinal cord. And we again fixed the lumbar element of the spinal cord to stabilize the imaging. And we were able to get cross-sectional as well as sagittal reconstructions in 3D. So this is kind of an image of the 3D image that we kind of capture, and we take about 15 sagittal slices, and this is kind of the epicenter. You can see again the disruption of the central canal, whereas the central canal can be seen in injured spinal cord. And if we were to maximally contrast this using threshold, we could see kind of the area that's impacted with the hemorrhage in the lesion. So this is a kind of a clearer, larger image of what we get from B mode using very high resolution ultrasound. So you can see a very clear central canal in all of the images. If your spine, if the spine is very well aligned, this image is usually runs completely. The central canal usually runs intact, edge to edge. And you can also get the nice cross-sectional images that visualizes various anatomical features of the spinal cord. When we overlay power Doppler on top of this, we're able to get a pretty good resolution of the vasculature, and these mostly are targeting the larger arteries and arterioles, around 100 microns resolution of the arteries here without the use of a contrast agent. We're able to kind of take a look at the strength of the intensity of these vessels to see the strength of the flow and any impediments to the actual vasculature. And if we go ahead and take the sagittal slices and reconstruct it, we can actually get a 3D reconstruction of the vascular network involving these larger vessels. And this is kind of an image looking at intact spinal cord versus 90 minutes and 24 hours after injury. So you can see kind of the lesion beginning to form 90 minutes after. It kind of disrupts the vessels in that area, and as the lesion expands in secondary injury, you get an expansion of that disruption of the vasculature. We then try to correlate this with some of the histological features. So when we embed the spinal cord and cut it open, this is the very same cord from that animal. You can see a very good correlation of the vascular disruption that we get from B mode, as well as the HELFB staining that we get histologically. So it has an excellent correlation to histological data. So some of the conclusions we got from this study was that very high resolution can provide excellent resolution B mode images through our acoustic window, and we used a mounted stereotactic frame that's capable of a motorized sagittal acquisition that allows for 3D reconstruction of the cord, which has never been done before. And we were able to quantify also the quantification of hemorrhage correlates well with all of our histological assays. So we went on to apply this technique through many different studies. We looked at the intervention using immunoglobulin, and we saw that it was capable of rescuing a lot of the vasculature in the area. That was work from John Chio, one of our PhD graduates, and Anna Badner and we did some work looking at the infusion of mesenchymal stromal cells, which are cells that are well known to rescue various vascular disruptions. And in this particular paper, we looked at 3D reconstructions of the cystic cavitation that's formed in a rat. So we're able to use sagittal slices and quantify the 3D reconstruction of these cystic cavities that are formed after spinal cord injury, and we're able to perform quantitative lesion volume analysis based on some of these reconstructions. And lastly, we looked at the secretome, which is the conditioned media from these mesenchymal stromal cells, and we also were able to show that these conditioned media, when administered compared to vehicle, could rescue tissue and to improve tissue sparing and reduce lesion volume after injury. So I'll spend the last couple of minutes kind of talking about the state of the art. So the current state of the field is we want to move towards super resolution ultrasound imaging. And to do this on B mode is extremely difficult, but in terms of vascular injury with the contrast agent, there has been a movement towards the field to enhance the resolution that you get from contrast enhanced ultrasound. So it leverages the intravenously administered gaseous contrast agents. These are microbubbles to visualize tissue perfusion. So that's the same technique that's been done for all of these years, but now using techniques that are borrowed from optical microscopy. They take images of the ultrasound scans at high frame rates, about 500 frames a second. And using this, they're able to create super resolved maps and vascular networks by tracing the movement of individual microbubbles inside the actual image. And I wanted to show just like a video of this if it does play, but it may not. It's like an embedded YouTube video. I don't know if the AV can actually manage to play it. It's like an embedded YouTube video. It may or may not play. But if it doesn't play, that's okay. What it's trying to show is that this is actually of a heart, and you would see individual bubbles that are being traced along the lines here. And as you follow, as you take high frame rate pictures, you can track the movement of individual microbubbles through the system. And by doing that, it can actually characterize the vascular networks that are flowing. And several applications of this have been done inside the central nervous system. They further enhanced this kind of tracing with deep learning. So by looking at images of vasculature and the way microbubbles traverse inside the vasculature, they were able to perform a deep learning algorithm to better predict the way the microbubbles move and the images that are formed from microbubble flux. And they managed to do this inside a Nature Methods paper published just a while back. They were able to do it inside the brain to get very high resolution vasculature maps that were generated from contrast-enhanced sonography, and also able to do this in Dr. Hofstadter's lab using in the spinal cord as well, getting high resolution maps of the spinal cord. And so in the future, we would like to perform non-invasive ultrasound for gross tissue morphology, to continue doing this in our lab. But ultimately, we would like to use transcutaneous contrast-enhanced microscopy in order to get super resolution vasculature maps, not only to better understand the vasculature after injury, but also as a functional readout to a lot of our therapeutic interventions. Thanks very much.
Sure, we have time for one quick question.
Hey, James, good job, man. I just had a quick question. How big is the catheter or the probe? Is this the hockey stick probe, or?
You're talking about the transducer for the? Yeah. They're pretty large. They're like about 2 centimeters large at the tip.
Okay. Have you guys investigated like smaller probes?
Yeah. So the contrast, the group that performs the contrast enhanced imaging, that probe is a lot smaller. Yeah. So they're able to actually get in there with not too much of an acoustic window.
Yeah, because cardiology does it with like their small angiograms. They'll do like microbubble enhanced.
So I think now a lot of the small rodent research has moved towards that. Yeah. Like with the contrast enhanced imaging, that's what they do. The probes are super tiny, and they place it raw on top of the spinal cord.
So I think one of the cool things to investigate would be like map because when we augment map parameters in spinal cord injury after in the ICU, doing non-invasive or minimally invasive like probe, where you can actually get a small acoustic window between the lamina to be able to see if there's any perfusion changes at the level of injury would be an interesting study to do.
Yeah, for sure.
Thank you.
So our final speaker in this session will be Dr. Margaret Cheng, and she's going to speak on MR imaging for next generation therapeutics.
Awesome. All right. So first of all, I want to thank the organizers for inviting me to give this talk. I am a biomedical engineer from the Institute of Biomedical Engineering at the University of Toronto. And what I'm going to do today is to share with you some of the work that my lab has been doing on creating MR technologies, magnetic resonance imaging technologies, to guide stem cell therapy, and a little bit of I'm just going to show you a glimpse of what other things we do, okay, beyond stem cell. But most of this talk is going to be focused on guiding stem cell therapy. So just a little bit of background. I guess with this audience, I don't need to give a really detailed background on cell therapy. We know that a variety of different cell types could be applied to regenerate new tissue, for example, in cardiology and neural regeneration. Use of stem cells has been explored, universally in a lot of centers around the world. We can also use cells like CAR T cells, for example, in cancer therapy to home in on the tumor of interest. But rather than getting into the details of all the different cell types that people have used for cell therapy, I just want to focus on the obstacles that impede progress to date. Okay. We all know, those who work with cell therapy, that when you inject cells into the body, you will see massive cell death. Normally, within the first 24 hours, you'll get over half of your cells dying, and by 1 week, normally over 90% of your cells will be gone. This has been my own experience in my own preclinical models of cell transplantation. Now, because of this massive cell death, it is actually really impossible for us to ascertain if cells are retained, okay, that's one thing, and if when we do get a positive mechanism of action, for example, if we do get regeneration, if that regeneration can actually be attributed to the cells that were injected. Right? So in order to dive deeper into this problem of how can we visualize the cells that we are injecting or transplanting into the body, we have to turn our attention to non-invasive methods for imaging. Now, in this slide, I've listed a number of techniques: magnetic resonance imaging, MRI at the top, there are nuclear medicine techniques, SPECT and PET, X-ray techniques, ultrasound, and also a variety of optical methods. But if we want to focus on deep tissue imaging, meaning imaging without any limits on how deep we go, it's really the first 4 technologies that we can actually utilize, right? Because these are essentially cross-sectional 2D imaging across a stack of slices. Now, when you look at this list, the top 4 that I've circled here, I'm ruling out SPECT and PET because the spatial resolution is very low. This technique is sensitive, but the spatial resolution is typically too low for us to really follow our cells with high precision. So that leaves us with MR and X-ray, or CT. But when we look at the 4th column, sensitivity of detection, you could see that CT methods for following cells are very insensitive. Now, for the rest of this talk, I'm going to focus on MR methods for cell tracking. Okay. And without giving you a slide and taking you through a long background of how MRI physicists have tried to do cell tracking for the past 2 decades, I'm just going to show you this one image right here, okay? And the title of this slide is Conventional Cell Tracking. It's non-specific, and it has the problem of signal dilution. So what we have here is an experimental model. It's a marine heart that had iron oxide mesenchymal stem cell labeling. Okay, so we've got these mesenchymal stem cells labeled with iron oxide and then injected into the myocardium. And you can recognize the site of injection by virtue of this dark hypo-intense signal, okay, here on the left ventricular wall. Now, this is what you see immediately after cell injection. Nice, bright, well, not bright, nice, clear, dark area. And that hypo-intense region persists up to 4 weeks post-cell implantation. The authors of this study thought, this is great. We've got stem cells persisting and surviving out to 1 month post-implantation. But what they found at 4 weeks was that for the mesenchymal stem cells that they injected, there was actually no DAPI-positive cells found on histology. What does this mean? This means that all of the stem cells that were injected 4 weeks earlier had all died, okay? And when they did histology, you could see with this H&E stain, blue staining for iron, okay, coming from the iron oxide that was used to label cells, this locations of iron staining coincided precisely with the CD68 positive stains for macrophages. So what these authors showed was that the dark signal that they saw at week 2 and week 4 did not actually come from the original mesenchymal stem cells that were introduced into the myocardium. Instead, those cells had all died, released the iron oxide, and the iron oxide was taken up by infiltrating macrophages. Okay? So this is why with conventional cell tracking techniques, we've got this problem of non-specificity. If you see a dark signal, it doesn't necessarily come from your cells of interest. And signal dilution, which I haven't actually talked about here. Let's suppose that your cells do survive, okay, out to 4 weeks. Let's say 100% of your cells survive. If the cells are doing their job, you want them to proliferate as well, right? Maybe not hundreds of times, but maybe a few times. And you can imagine that as cells undergo one replication, 2 replications, the finite amount of iron oxide label that you used for labeling is going to get diluted out amongst that proliferating population. So even if your cells don't die off, we are faced with this problem of signal dilution. So what can we do? Well, over 10 years ago, people in the MRI community looked at methods that other people using other imaging modalities used, and they said, why don't we use reporter genes? Except this time we'll use MRI reporter genes. And the advantages of using reporter genes are manifold, okay? First of all, you get the cells of interest to express this reporter, meaning that the contrast is generated intracellularly. And that contrast will not get diluted out with cell division. So theoretically, your cells can divide once, twice, 3 times, 100 times, and your signal will not get diluted. The second advantage is that it is very specific. That contrast cannot get transferred to macrophages that do not have the genetic label, right? And so this represents a really promising way for longitudinal cell tracking on imaging. Now, with MR reporter genes, people have published on ferritin, published on divalent metal transporter, water transporter, a number of different things, but ferritin is by far the most widely used and the most widely reported. And you start wondering if ferritin is so useful. Okay, so ferritin, as we all know, it's ubiquitous iron storage protein found in all living things. Okay, so if ferritin is so useful, why hasn't it taken over exogenous cell labeling? Why are we still using iron oxides labeling cells outside of the body and then implanting them? The reason is because the sensitivity is extremely low, and I'm not going to show you images. Just trust me, the sensitivity of the ferritin reporter gene is extremely low compared to what I showed you on this slide. That involves exogenous labeling. Okay, so a few years ago, a PhD student in my lab, Daniel Schultz, discovered that we can actually use this ferritin platform, but not with the iron metal. Okay. Instead, what we use, and this was a really serendipitous finding, what we found was that cells that overexpress the ferritin protein can actually form manganese ferritin nanoparticles. The cells have the machinery to create these nanoparticles, and that particle will give us a bright contrast on MR. So it's not a dark contrast, it's a bright contrast. I'm just going to explain what this slide shows you here, okay? So here we've got these not-skid immune-compromised mice. They're about 25 grams. And they're imaged on a 3 Tesla human scanner with a wrist coil. So for those of you who are wondering, how can I image small, tiny animals on a human scanner? You can just use a very small coil, okay? Then you get the signal to noise. First image okay, so it's on your left, okay, on the mouse's right. The left leg, you could see no signal. Right leg, also no signal. So what we have here is that on your left, we've got mutant ferritin overexpressing cells injected into that leg. On the contralateral leg, we have wild type cells injected. So both legs have cells, but only the left leg has the ferritin overexpressing cells. Okay? Now, when we apply a manganese contrast agent, okay, and manganese gives us bright signal on MR, what we get in only the ferritin expressing cells is a bright contrast, and you can appreciate that this contrast is very significant, okay? Far above the baseline fluctuations in signal. You don't get that signal in the contralateral leg because that leg has wild type cells. Now, this signal persists but dies off a little bit, and after 5 days, by day 7, the signal is completely gone. Okay, and I'll explain why that is. Now this graph here, if you look at this black line, okay, you could see that the bright signal goes up a lot from baseline, sustains for about 5 days, comes back down. We also compared this mechanism against other reporter genes, okay, against a divalent metal transporter, DMT. It gives us a bright contrast as well, but it's clearly not as sensitive. And when we compare against normal ferritin, which gave us no signal, that was absolutely not useful. Okay, so you could see that with normal ferritin, the bottom graph, there's actually no signal increase. Why is this happening? What we did was then we went back to the bench and we tried to find out what was actually going on. So these cells with the ferritin overexpression were taking in the manganese and creating these particles that gave us a bright contrast. They're also being recycled through the normal cellular pathway. So we now see a lot of punctate dark dots. These are actually our particles being recycled through lysosomes, okay, inside the cell. And my student, Daniel, precipitated these these electron-dense metal particles out and imaged them on transmission electron microscopy, TEM, and you could recognize these where the dark circles are. They're about 6 nanometers in diameter. So this method is actually really safe. We are not overexpressing ferritin by a whole lot. We're just overexpressing it by a factor of 2. And when we quantified on chemistry how much more manganese these cells are uptaking, it's about 2.5-fold. So you look at this black bar compared to the wild type, it's about 2.5-fold. So not a whole lot, okay? Now since then, my current grad student, KU, has taken on this work and used the system on human embryonic stem cells because the end goal is we want to be able to differentiate these human embryonic stem cells into a lot of different cell types and see if we can apply it to different types of applications. Now what we have here is just a viability study. She had the ferritin overexpressing cells in this panel, wild type cells on the left, and doped them with either no contrast agent or with 0.1 millimolar of contrast agents, and you could see there's no impact on the viability. She also did a bar graph. I didn't want to clutter the slides, so I'm not including that here. She also looked for stem cell markers and noted that nothing was affected from the overexpression or dosing with our contrast agent. Now, this is the piece that I recently, piece of good news that we both recently celebrated just less than a month ago. Again, my student took these human embryonic stem cells and injected them into the leg muscle of an immune-compromised mouse. Now, you know that your stem cells are living, they're viable, if you are able to form a teratoma, right? So the formation of a teratoma is the acid test for testing if your stem cells are indeed stem. So what she's done here is she's injected cells into this leg of a mouse, okay, her ferritin overexpressing cells, administer our contrast agent, and you could see that on day 1, there's a bright signal. Now, this bright signal is not as bright as what I showed you previously. This is a different cell type, okay? So in human embryonic stem cells, we get a bright contrast, but it's not the huge contrast increase that we saw earlier. Contrast is sustained for at day 3, and by day 5, there's barely any left, and we expect this. It's supposed to be recycled. Now, a lot of the cell population died as we expected, but she waited patiently, kept scanning the animals longitudinally, and at week 4, I don't know if you guys can see this, there's this little rice kernel bright dot where the yellow arrow is. Can everyone see that? So she was skeptical. She said, this is probably an MRI artifact. And I said, no, this is not an artifact. There's no indication that this has any regular appearance to it. And lo and behold, 6 weeks later, we did not even need to apply our contrast agent to visualize it. It was seen on a T2 weighted scan. And for those of you who work with MR, you know that T2 signifies water, right? Enhanced water accumulation. When she took it out on histology, confirmed that this lump here was indeed of human origin. This was a teratoma that she was able to successfully form in over 80% of her mice. Okay, so this is the first demonstration in the literature ever that we are able to recall signal from an MRI reporter system long after the signal seems to have disappeared. When the cell population comes back up, we get that signal and we can recall it by simply administering our MR contrast agent. Okay. So now this slide shows work that I've been doing in collaboration with Dr. Failings, and that is, can we now use this platform, Bright Ferritin platform, to track neuroprogenitor cells in a spinal cord injury model. And in this slide, what I wanted to compare was our Bright Ferritin method, okay, here on the bottom, against exogenous conventional approach, which is labeling the neural stem cells and then implanting them into the spinal cord. Now, if you look at this sagittal view of a rat, these are not mice, these are nude rats. They're about 250 grams in weight. The region where the cells were injected is really clearly depicted, right, by this bright signal. Now, by comparison, the Bright Ferritin is a lot less bright, and for me as an MR physicist, and I look at this as, well, it's hardly anything, but just wait, okay? So I'm showing you also an axial view. You could see that the spinal cord, okay, has this butterfly-like region that's really bright. You don't really get that for the ferritin system. Now I do a T1 map, okay? So T1 map quantifies the T1 relaxation time. Here we are. This is the T1 map for the Bright Ferritin injection, and you can see that there's this blue area here within the spinal cord that indicates where the stem cells were injected, okay, with the Bright Ferritin system. So I just want to say that, you know, if you don't see something on a grayscale MR image, it doesn't mean that the pathology isn't there. The reason being, I can see virtually anything on a T1 map because I'm actually quantifying how much I'm changing the physical properties of cells and tissues. With a T1 weighted image, grayscale image, I need to know precisely what is the T1 of these cells in order for me to optimize the sequence for the grayscale image. Now that I have the T1 information from the T1 map, I can go back and optimize this sequence for the grayscale imaging and be able to bring out that bright contrast. But you wouldn't be able to do this normally, right? Because when you run sequences on a scanner, they're preset. So they're preset to the things that you are normally going to see. They're not going to be optimized. They won't be optimized for the things that you are just curious in looking at. So I'm just going to wrap up here very quickly. That's the work that we've been doing on stem cell tracking. We also have a new chemistry platform where we can now track biomaterials that you implant into the body. So I'm an engineer, I'm not a physician, so we make up crazy stuff that may have no clinical relevance, but the materials have clinical relevance. If you look at this image, you could see this bright, kind of like a, I don't know, a Boston cream donut, without the cream inside. You know, you've got a Boston cream donut in the middle, nothing, it's flat. That's a polyurethane implant. So it's a polymer implant that my collaborator, Dr. Paul Santerre, his student created. And our agent, our chemistry agent, chemical agent can now label polymers through a radical polymerization process. So any polymer that forms through radical polymerization can utilize our chemical compound. We can also label collagen, alginate, you name it, so natural and synthetic materials. And the reason why this binding is useful is because it's covalently, works through covalent binding. Our agent is actually covalently bound to the material such that when we let this material degrade over the course of 7 weeks in vivo, we can use the signal intensity and the T1 changes to tell us how much of the biomaterial remains in the body, okay? So on this last slide, the black line here represents unlabeled, green is labeled. You could see that when the graft is unlabeled, we severely overestimate how much volume it's taking up. This graph here on the upper right shows us that with the label inside, with a chemical compound, we don't alter the rate of decay of the polymer, which is important because we don't want to change the material property. And obviously, as the material is degrading, you can expect the amount of contrast agent to degrade with time, right? It will come down. So this is a really exciting platform. We are using it to now track natural materials that we are using, collagen and alginate and gelatin. And if there are any biomaterials that you guys are interested in the spinal cord repair work that you do, be happy to talk. So I just want to acknowledge again all the people who've worked hard on some things I've presented today, along with my collaborators. And particularly, I want to note Michael Laflamme, Michael Failings, and Hai-Ying Mary Chang, who've worked with me on this stem cell tracking technology. Thank you.
We have time for one quick question. Dr. Yi?
It's terrific, really, really fascinating work.
Thank you.
I guess in terms of the next phase, or when you think about it, a lot of times when we go to the clinic, we're going to be probably thinking of stems or cells along with the materials together as a delivery, a combined delivery. So I guess any thoughts in terms of, I guess, the next phases?
Yeah,
Yeah,
I've thought a lot about that, and the only way to do the tracking of both the cells and the materials is to have something that is multiplexed. So using one contrast alone will not be sufficient. I've thought of other ways where we can use different resonant peaks on MR, so that one resonant peak could be tracking cells, another resonant peak could be tracking materials, but I haven't thought it through clearly. It's absolutely something that will require more than just one color. Yeah, but we are working on it.
Very exciting. Thank you.
Thank you. Thank you.
Okay, so I know everyone's getting hungry for lunch, but we're going to have our final elevator pitch presentations now, and they're all quick. So that's the great part of it. So let me see how to, I guess we're pulling them up from AV. Okay, so we're going to start off now, and these are the clinically focused elevator pitches, and so we're going to. Okay, I'm going to tell you who's on deck. I'm going to call, so Armin, 10 seconds before your wrap up, you're going to get the yellow sign. Okay, so we're going to start off with Armin Malhotra, who's a PGY4 neurosurgery resident, then Bryce Thompson, and then Ahmed Cherry. So we have 1, 2, 3 on deck. So come on up, Armin.
Thanks very much. Do I switch slides or? Okay, I can go ahead.
I'm not sure.
Yeah, as mentioned, fourth-year neurosurgery resident supervised by Jeff Wilson. So excited to talk about our cervical myelopathy severity index. We know and have heard this morning that measurement in cervical myelopathy is a critical area that requires more research. Specifically, understanding important clinical changes in the mild myelopathy cohort has motivated our efforts to develop a new patient-centered cervical myelopathy scale. The MJOA, which is the existing gold standard, is limited by sometimes arbitrary response weighting hierarchies. So at the outset of this study, we aim to develop and test the measurement properties of a new index. To accomplish this, we applied a mixed methods approach using both clinicians and patients. So prospectively, we recruited 98 patients and 51 clinicians. The clinicians were all spine surgeons, and we went through an iterative process of item reduction, starting with 42 candidate items, and using patient-derived severity ratings and importance ratings for each item. We moved through and refined this 42-item list to a final 14-item cervical myelopathy severity index. Next steps involve assessing this compared to the MJOA longitudinally in a multi-center fashion. Thanks very much.
Okay, so next up we have Bryce Thompson.
so I'm a PGY3 in radiation oncology. I was supervised by Arjun Sehgal. And so for my project, I looked at the outcomes for breast cancer patients treated with spine SBRT. We wanted to look at vertebral compression fracture, local failure, and overall survival in our retrospective cohort of patients treated between 2008 and 2023. So we identified 168 patients and 409 spinal segments treated with SBRT. The local failure at about 1 year was 5% and 14% at 5 years, and then overall survival at 1 year, about 90%. Local failure at 5 years was about 45%, and vertebral compression fracture was 10% at 5 years. So overall, we found that there was no association with molecular status and these outcomes, but the predictors for local failure were the breast cancer patients who already progressed on multiple lines of systemic therapy, and the breast cancer patients who were treated with a mean dose of less than 33 gray. Overall survival predictors were patients who had lung and liver metastases who did worse, as well as patients who were treated with multiple lines of systemic therapy also doing worse. And then overall for vertebral compression fracture, the patients who had SINS deformity or baseline vertebral compression fracture did more poorly. So overall, this shows that SBRT can achieve really good results for local failure, which should be considered in breast cancer patients due to their long overall survival of up to 5 years for about 50% of patients.
Okay, and next up, Ahmed Cherry. And then after that, we have Hussein Shakil and Jane Jomi, and then Joshua Plinner, just so you know who's on deck.
Hey, thanks everyone for having me. So I'm presenting some of the fellowship data. Dr. Kumar indicated a little bit well about the previous diploma program, but essentially the background of this is that spine surgery fellowship includes trainees from both neurosurgery and orthopedic surgery, and is increasingly undertaken fellowship preparation careers to move forward. As Dr. Failings, Dr. you mentioned prior that University of Toronto and Canada were working on a diploma program for this. So we collected data from 2015 to 2022 from the fellows who entered this information into the DRES program, which is on for the University of Toronto, and we essentially were able to amalgamate all this data. So what we found, there's over 9,000 cases logged over that period of time, with over 1,300 cases per year. The diagnosis of surgery were primarily degenerative or inflammatory, which kind of mimics what we see in the community and primary in the programs. The higher number of cases performed by a single trainee was over 230 cases, with the average of over 150 cases per trainee per year. It indicates here was 77, but this was actually adjusted for some of the early years. And as you can see here in two of our diagrams, you can see primarily that the lumbar procedures are which kind of lead the way, as well as cervical, which again mimics what we see in the degenerative community. And then finally at the bottom we can identify the different hospitals that we are able to accumulate this data. And as the programs over the years this has become a part of the requirement, and you can see that there's more entries. And the reason why we've done this, it's an effective method to document the information and to document the exposure, and this will be used in the diploma program for the Royal College. Thank you.
Okay, and next up we have Hussein Shakil.
Hi, my name is Hussein Shakil. I'm a fourth-year neurosurgery resident, and this is an economic evaluation we did comparing early surgery and observation for patients with mild myelopathy. We all know that degenerative cervical myelopathy represents a significant care burden for the healthcare system, largely related to it being the most common cause of acquired non-traumatic spinal cord injury. Current guidelines recommend either surgery or observation for patients with mild forms of this disease. In this study, we wanted to compare these seemingly alternative strategies with respect to patient quality of life and healthcare costs. We employed a statistical technique known as Markov modeling to get lifetime estimates for patient quality of life, as well as healthcare costs derived from data from the CSM North America and international trials. Specifically, we use the SF6D scores from the trial data and link these to microcosting of cases done at the Toronto Western Hospital. Essentially, these two graphs in the middle panel show that over a robust set of sensitivity analyses that early surgery is cost effective. Specifically, it's associated with about 1.26 quality of life years gained for the patient, which is equivalent to about $12,000 per quality of life year. As a reference, the WHO defines cost effective as $74,000 per quality of life year. So these results suggest that early surgery is cost effective, and moreover that it is associated with material gains in patient quality of life. Thanks.
Okay, and next up we have Jane Jomey.
Good afternoon. My name is Jane Jomey, and I am a medical student at the University of Toronto. And today I'm presenting on our work on enhanced recovery after surgery, or ARAS for short. ARAS is a patient-centered and evidence-based care pathway that surgical teams can use to reduce a patient's surgical stress response, facilitate recovery, and optimize physiological function. Great, thank you. Examples of ARAS protocols include preoperative patient education, antimicrobial prophylaxis, early immobilization in the postoperative phase. We conducted a systematic review of the literature, and in spine surgery, when applied, ARAS can reduce the length of stay, postoperative pain and opioid consumption, surgical complications, and cost. There is an opportunity to apply ARAS in patients with degenerative cervical myelopathy. Potentially for patients who are younger and healthier, ARAS wouldn't have much value. However, for patients who present later in their course of illness, who have neurological impairment, who have underlying mental health concerns, and who have increased pain, ARAS protocols, particularly for DCM, should be developed. Thank you for listening.
So I think you're up twice, right? Okay, so after Joshua's up twice, we have Raghavan, and then Tiffany, and then Daniel. Just so people know who's on deck.
Do I do something? Or click this?
Let's see. Yep, got it.
Cervical radiculopathy results in pain, sensory loss, and muscle weakness, resulting in significant impact to individuals' daily activities. Conservative interventions are typically first-line treatment, with the majority reporting symptomatic improvement. The aim of our systematic review was to assess the effectiveness and safety of conservative interventions for cervical radiculopathy. We searched 5 databases using the Cochrane Risk of Bias 2 tool and assessed the quality of evidence using GRADE. As you see on the screen, there's very low certainty evidence for the use of acupuncture, prednisone, cervical manipulation, low-level laser therapy, and thoracic manipulation. And there's low to very low certainty evidence for the use of multimodal treatments for improvement in pain, function, and range of motion. What we found was that conservative interventions were found to be safe, with only minor adverse events reported. As well, there's inconclusive evidence for pain reduction following conservative interventions compared to surgery, which was rated as very low certainty evidence. As cervical radiculopathy is expected to increase in prevalence, this information can be used to help guide clinical practice, but although very low certainty evidence was found, there's a lack of high-quality recommendations that we can provide. Future research should aim to increase the quality of evidence and help to improve guidance to clinical practice moving forward. Thank you. Imagine yourself starting to get neck pain, arm and hand pain, numbness, tingling, and weakness. You're unable to perform your daily activities, and your quality of life is decreasing. You have a long list of questions in your mind. What's causing these symptoms? What's going to happen? What can I do about it? How long will I have them for? We wanted to understand the lived experiences of patients with cervical radiculopathy. We purposely recruited individuals who were 45 years of age and older, and we assessed them and we interviewed them through Zoom. We identified 3 major themes: the biopsychosocial impact of this condition due to the physical and psychological distress, the role of healthcare providers, which can act as facilitators or barriers to their recovery, and uncertainty experienced due to the condition due to the unpredictable nature of these symptoms. The findings of our study provide the first account of the lived experiences of this condition and can be used by clinicians moving forward to help provide patient-centered care. These findings are the first to understand this, and future studies can work to improve and understand the patient-provider relationship and seek ways to provide further insight to enhance care. This work will result in helping to create a non-operative bootcamp program for this condition, making sure that patients' experiences and views are made highly relevant within this program. Thank you very much.
Great. Next up, Raghavan Manoharan.
Thank you. So we wanted to look at patients who are having surgery for degenerative lumbar conditions, and we wanted to predict adjacent level disease and what factors, particularly radiographic factors, lead to patients coming back with adjacent level problems. So this is primarily a retrospective review of data from this institution over about 10 years. There are just over 300 patients. Our hypothesis was that the PILL mismatch is not relevant for this group, and we use this paper, which is on the bottom right of your screen, by Pesenti, that showed that most patients had physiologically 35 degrees between L4 and S1, regardless of their pelvic incidence. So when we looked at our own data, we were able to work out that the things that predicted reoperation were the presence of a spondylolisthesis, the amount of distal lordosis, and the pelvic incidence. And when we explored all of those factors together, what we worked out was that the cohort of patients that were most at risk were degenerative spondylolisthesis patients, and that's because they came in with very little lordosis between L4 and S1, and surgery didn't necessarily always correct that to physiological norms. So from the bottom line is that we think this 35 degrees of distal lordosis is important. We think the location between L4 and S1 is important, and we think that the most vulnerable subset is degenerative spondylolisthesis patients.
And next up, Tiffany Lung.
All right. Hi, everyone. I'm Tiffany. I'm one of the PGY4 orthopedics residents. My study evaluates the relationship between sleep quality and spine patient postoperative outcomes, as we don't know much about this topic. Intuitively, it makes sense that poor sleep equals poor function, as I'm sure we can all relate to. And so the purpose of the study is to evaluate the relationship between pain-related sleep disturbance and 1-year postoperative outcomes in patients undergoing surgery for degenerative thoracolumbar conditions. We took about just over 4,000 patients from the CSORN database. They were recruited from 2015 to 2021, and we divided them based on their sleep disturbance at baseline and their first postoperative follow-up. We ran a multivariable logistic regression model that controlled for various factors, including comorbidities, their baseline sleep quality, and their patient-reported outcome scores. Primary outcome was the odds of attaining clinically important improvements at 1 year in various patient-reported outcome measures. And what we found was that patients with worse or ongoing severe sleep disturbance were less likely to achieve improvements in function at the 1-year mark, and patients who had improved sleep were more likely to achieve improvements in function at the 1-year mark. So potentially next steps could be improving perioperative sleep to optimize surgical outcomes.
And finally, we have Daniel Palhares.
Thank you so much. Good afternoon. So, international contouring guidelines, they were developed to guide specifically sacrum SBRT treatment. However, there's no evidence validating the adherence to these contouring guidelines. Therefore, the goal of our study is to review our sacral SBRT patients treated at Sunnybrook, intending to validate the contouring guidelines for sacral SBRT. We reviewed 215 sacral segments in 112 patients, and the primary endpoint was MR-based local failure. We identified that 16% of segments were under-contoured per consensus guidelines, and those under-contoured segments had twice the risk of local failure compared to those segments that followed the guidelines recommendation. On multivariate analysis, contouring deviation, extraosseous extension, and radio-resistant stallage were independently associated with increased risk of local failure. As we increase the number of local failure, as we increase the number of risk factors for local failure, the local failure increases from 7% to 57% at 1 year. In conclusion, sacral SBRT is an efficient treatment, and adhering to consensus guidelines for target volume delineation is recommended, as it is an independent predictor of reduced risk of local failure. Thank you.
Okay, I don't think I've missed anyone, and I think this is our key, Nadia, correct me, but for lunch. So I think we're all back here at 1 o'clock? At 1:30, sorry, at 1:30, and please enjoy lunch, and thank you for great presentations this morning.
Orthopedic surgery and neurosurgery. And this year, it gives me a great privilege to welcome Dr. Lauren Hashem. She is in the surgeon scientist training program, completing her PhD under the supervision of Dr. Michael Failings. And she'll be speaking to us on harnessing the endogenous stem cell response after spinal cord injury. Thank you.
Thank you very much. Good afternoon, everyone. My name is Lorena, I'm a PGY4 neurosurgery resident. And today I'll be talking about some of the work I've been doing throughout the PhD, really trying to study the fundamental biology of endogenous neural stem cells, understand their mechanisms of activation, and try to use that knowledge to help inform therapeutic strategies with high translational potential. So I have no disclosures to make. So when we look at the spinal cord, on the left is a schematic, and on the right is a cross-section at the cervical level of one of our reporter mouse lines. You can see in the central canal region, there's this population of cells known as ependymal cells, and there's been a growing body of work showing that these cells do contain stem cell properties. And when we look at an uninjured animal, and even in humans, these cells remain largely localized to the central canal region. So in this mouse, these stem cells are labeled with TD tomato or red reporter lines, so we can track them and see their behavior in the setting of injury. But in general, in a normal, healthy cord, they remain, as you can see here in the image. There's been this phenomenon that's been described about a decade ago that in the setting of traumatic spinal cord injury, these cells become activated. And you can see here on the right, this is 7 days post a cervical clip contusion model in our mouse model. You can see that these cells start to migrate out from the central canal region. They primarily differentiate into astrocytes. They secrete beneficial trophic factors, and there's been a growing body of work showing that they are actually important regulators of neuronal survival and endogenous regeneration. So despite this, this kind of phenomenon that's been described in both rodents and humans, the mechanisms that actually activate these cells, what underlies that phenomenon you saw in the previous slide, has remained elusive. And all of this kind of activation state is largely limited to the acute period. So when we look at subacute or chronic injuries, where the majority of our patient population is in the setting of spinal cord injury, it becomes valuable to understand what's actually activating them acutely so we can try to manipulate and modulate those mechanisms in subacute or chronic injury. So this led to 3 questions, which I'll go through throughout the course of the talk. The first question is, what injury cue might activate these cells? And so when we look at spinal cord injury, there's a host of secondary injury mechanisms within the acute period. One of which we looked at was glutamate excitotoxicity. And so this is a hallmark in the acute setting. We know glutamate levels rise quite substantially within minutes of the injury period, and they remain high for a few days post the acute period. And it's known that this high toxic glutamate levels lead to neuronal and glial cell death. What we paradoxically found, so this was work just leading up to the PhD, was that these same toxic concentrations of glutamate that kill neurons and kill glial cells actually positively regulate these ependymal cells. So we can see here on the bottom, this is live dead staining, so green is live cells, red is dead. You can see with these toxic levels that match what we find in vivo in a spinal cord after acute injury, these cells were almost twofold increase in the number of live cells and a reduction in cell death. So we termed this kind of the paradoxical glutamate response, just given the fact that these high concentrations of glutamate that we previously thought were solely a negative factor in the acute period might actually drive these cells to divide. The next question is, what is the underlying mechanism behind this paradoxical response? So obviously we can't be putting more glutamate in the cord, but if we were able to understand what the downstream molecular targets were, potentially we could now start modulating that in other injury settings. So this is work that just came out, and essentially, this is a schematic, and I'll go through key parts in the next couple of slides, but we discovered that this response is dependent on this special kind of unique receptor, the AMPA receptor, which is a subtype of glutamate receptors, and specifically the calcium component of these receptors. So I'll talk a little bit more about each aspect. So starting at the receptor level, you can see here these are single-cell patch clamp recordings in these ependymal cells, and so when we stimulate with glutamate, you can see there's a large ion influx into the cell. Every time glutamate was pulsed, we see the cell was responding. MBQX is an inhibitor of those AMPA receptors that I mentioned, and we can see that there's a complete abolishment of this influx. Now, this graph here only looks at ions in general. We wanted to focus specifically on calcium, given its important mechanisms in cell regulation. And so this is FURA2 assay. And so when you stimulate the cell with glutamate, you see a very large influx of calcium. Again, when we treat with this AMPA blocker, so this pharmacological agent, we lose that effect. We wanted to further show that this was indeed an influx of calcium, so EGTA removes all calcium outside of the cell, so it's a calcium chelator, and we saw that this increase in glutamate was again lost when we removed all the calcium. So it's telling us that glutamate leads to calcium influx in these cells via AMPA receptors. Going a little bit further down, these receptors are quite complex. There's 4 different subunits, so we wanted to then know what were these receptors comprised of. So there's 4 subunits here, GRIA 1 to 4. Interestingly, we found that these cells, this is transcript, so we did RNA sequencing. We found that these cells do not express GRIA 1, which is one of the more highly expressed subunits in neurons. So again, these are a unique population of cells that do deserve a kind of studies directed specifically at them. So what remained was GRIA 2 to 4 genes. Won't get into the complexities of the composition, but essentially you can have 2 types of AMPA receptors, one that allow calcium and one that does not allow calcium into the cell. And this is largely dependent on this GRIA2 gene. So you can have unedited or edited GRIA2. If GRIA2 gene becomes edited and it's present in the receptor, the cell becomes calcium impermeable, and if it remains unedited, then you have calcium permeable receptors. What we found, you looked at basically the codon at this one position in the receptor will dictate that property, whether it's CGG or CAG, and we found that these cells were expressing primarily CGG, which is the edited form. All in all, this essentially tells us that these calcium-permeable AMPA receptors that we previously described in the previous slide are comprised of GLUA3 and GLUA4 subunits, and it lacks this GRIA2 edited subunit. The rationale for doing that is that we can now use pharmacological agents that can target this specific receptor. So these calcium-permeable AMPA receptors that are comprised of that unique composition of subunits has a pharmacological agent. So IAM 1460 is a calcium-permeable AMPA receptor blocker. So when we treated cells with glutamate at these high concentrations that you saw in the initial slides, we can see again these high, kind of the green at the bottom. I don't know if you can see my mouse. But essentially in the first panel, you can see significantly more green cells with these high levels of glutamate. When we block with MBQX, which is a total AMPA receptor blocker, we lose that effect. But more importantly, when we block these calcium permeable receptors with that agent on the last panel, we again are able to lose that effect. So it's telling us these calcium permeable AMPA receptors are sufficient to drive that proliferative effect. And you can see the quantification on the right side. So that was all looking at survival. We did a whole transcriptome bulk sequencing and found that these high toxic glutamate levels were driving cells to become astrocytes. So you can see in the heat map at the top, the red means more highly expressed and blue is downregulated. So with glutamate treatment, all the key astrocytic transcription factors and pro-astrocytic genes were upregulated, whereas genes for neurons, oligos, and NPCs were downregulated. And you can see in the right panel side are immunostaining corroborating more GFAP positive astrocytes that had longer branches and were more extensive and more mature. You can see in the bottom graph on the right-hand side, again, GFAP quantification expression was increased with glutamate, and when we applied this AMPA receptor blocker, IEM 1460 in the last bar, it brought it down to control levels. So next we wanted to see what could potentially be the reason for these cells to largely become glial biased. One of the main questions in the field is, yes, these cells are multipotent theoretically in vitro, but how come in vivo they're largely directed and restricted to an astrocytic lineage? So when we go back to basic principles of neural stem cell regulation, and we look at the transcription factors that are involved, there's been this theory that these basic helix loop transcription factors, HES1, ASCL1, and ALA2, are kind of in constant flux and keep the neural stem cells in their immature state. And so when one transcription factor dominates, it's thought that it drives the cell down that lineage. So what we were finding on our RNA sequencing analysis is that these high glutamate levels were increasing the upregulation of HES1, which is a pro-astrocytic gene. And it's also known to be a downstream canonical target of Notch signaling. So a couple questions from this we asked is Notch signaling now some sort of having crosstalk with this calcium pathway that's not previously been described? And how could calcium permeable AMPA receptors be interacting with this mechanism? So going back to our schematic onto the left side, essentially what we found is that when we blocked gamma secretase, which is the downstream regulator of Notch, we essentially lost the transcription of HES1 in the presence of glutamate. And you can see here both on Western blot analysis and PCR on the right side. Blocking Notch signaling abolished that increase in the pro-astrocytic transcription factor HES1, and then this resulted in a loss of that phenotype. So we blocked Notch, we lost HES1, and we lost astrocytic differentiation in the presence of glutamate, which essentially tells us that this basal levels of Notch signaling is necessary for this effect. At the same time, when we blocked these calcium permeable AMPA receptors, we saw a very similar effect. And so this suggested to us that there was some sort of crosstalk with downstream Notch and calcium permeable AMPA receptors that's not previously been described. Onto the right side of the figure, which looks at survival, we found that there was an increase in phosphorylated Krebs expression when these cells were treated with high glutamate levels. And again, blocking Notch signaling abolished that effect, as did blocking CP-AMPARs, as you can see here. So all in all, that's great. We found a mechanism, but then the question was, how can we now translate these kind of very basic biology fundamental questions into a potential therapy that can actually be, at some point, applied to patients? So when we look kind of at this schematic here at the time course post-spinal cord injury, as I described earlier, we know there's high toxic levels of glutamate that rise in the acute period. At the same time, at parallels, there's this increase in the proliferation of these ependymal cells, all in the acute period. The question then became, now subacute or chronically, we know AMPA receptors are critical. Could we now use a drug that's a positive modulator of these receptors to potentially further increase the regenerative potential in subacute or chronic injuries? So there is this class of drugs called ampakines, or positive allosteric modulators, that have been used in other injury settings, in neurodegenerative conditions and in stroke and other animal models that we wanted to now apply in the setting of spinal cord injury. Now, when you apply a drug, obviously it's not targeted to these specific cells that we want to modulate. So we wanted to look globally and see, before we start modulating AMPA receptors, what is the composition and transcriptome of them in the setting of injury. And so this is bulk RNA sequencing in our spinal cord injury model, both cervical and thoracic, and we can see global downregulation of AMPA receptors and glutamate receptors in the cord, suggesting that these receptors are critical for plasticity and signaling. So if we were to have a positive modulator, it could also have side effects that would be positive on the neuronal signaling as well, because we know that these receptors are downregulated. So what we can see here is just a schematic of the paradigm of treatment. So this was a rat study. We did C6-7, again, clip compression model. And at 1 week post-injury, when those high levels of glutamate subside, we started treatment with this ampakine agent daily for 2 weeks. And what we found, so this is the central canal, and you can see on the left side just the immunostaining. We stained for Ki67, which is a marker of proliferation, and so you can see there's more proliferative ependymal cells in the drug treatment group, and the quantification on the right side. Same time, we found a global increase in GFAP-positive astrocytes, so this directly paralleled what we were seeing in vitro, now in in vivo setting with this drug. We also found that treatment with this positive modulator increased global levels of BDNF expression in the spinal cord, and we found more specifically it was largely, much of this BDNF was localized to GFAP-positive astrocytes. And then importantly, we found that there was an increase in neuronal sparing. So the top panel is looking at NUN, which is a marker for all neurons in both ventral and dorsal regions. And then in panel B, we did chat motor neuron staining, so looking at ventral motor neurons, and there was also increased survival of neurons there. Panel C is just a snapshot of some of the early behavioral data, looking at BBB motor subscoring, and so we were seeing these animals were walking better. And we've now completed a more long-term 6-week chronic study in our mouse reporter line, which is showing on multiple metrics of both forelimb and hindlimb motor function that this recovery is preserved. So kind of just taking a global step back and looking at the process of this, so kind of this work shows that we can identify a phenomenon that may have positive effects endogenously in the cord, look at the very basic biology of how that mechanism may be at play, and then try to look at targets that we could modulate either pharmacologically or through other means to try to translate to a therapy for SCI. I think beyond this work also kind of opens doors to look at other disease processes. So glutamate and AMPA receptors are critical in many other pathologies, so TBI, stroke, even setting of cancer stem cells. When we look at plasticity, rehab, and regeneration there, given the importance of glutamate signaling, so some of these mechanisms may shed light on how those rehab effects and activity-dependent changes can modulate our endogenous stem cells, and then obviously from a therapeutic target, looking at AMPA modulators in the setting of SCI. So I'd like to thank everyone from the Failings Lab, Tatter Lab, our collaborators, Peter Dirks and Graham Collingridge here in Toronto, as long as Jonas Friesen and Wei Liu, who've been critical in some of these transgenic lines and all of our funding sources. Thank you very much.
This paper is open for discussion, questions from the audience or online.
Can you hear me okay? That was amazing, Lorene. That's really cool. I'm sorry if I missed this, but in the subacute and then the more chronic phases, are the ependymal cells in vivo still giving rise to mostly astrocytes?
Yeah, so their activation's acute, and then they'll start to continue. The same cells that were kind of acutely activated, they'll migrate out and start to mature. They'll largely form the core part of the glial scar, so not the periphery. It's thought to be the positive part that secretes growth factors, and they've seen their co-localization of the astrocytes derived from them kind of overlapping with new axon regeneration, but they're largely astrocytes. A very small population will become oligos. So far, nobody's seen any sort of meaningful neuronal population.
Okay, and then the functional recovery is because the astrocytes are allowing for the neurons to survive better?
Yeah, it's thought to essentially attenuate the toxic environment and promote axon growth.
Have you thought about or I'm sure you have thought about it, but have you played around at all yet at some of those key transcription factors, like maybe knocking out a HES1 and balancing the scale towards, say, a neuronal differentiation?
Yeah, so I mean, that's a very good question. That's kind of the next steps of the work. So when we see now, like, glutamate's one of the main targets acutely. If you're able to essentially block certain aspects, on the flip side, could we now uncover or unlock a neuronal phenotype? So kind of the next step.
It's amazing. Thanks.
Thank you.
And I guess when you think of clinical translation, we're increasingly seeing more and more SCI in sort of the elderly, aged population and so forth. I guess with your animal model, is it an aged model, or is there would there be potentially different effects on the magnitude on the endogenous stem cell response?
Yeah, so it's a really good question. For this study and the mouse one that we've just completed, it was all relatively within a couple weeks, so just adults. We haven't looked at aged, which would be like mice that are past, I guess, a year. There have been questions in terms of just looking at stem cells in general. When we look at embryonic and fetal and adult, there are differences in the way they behave. So nobody's ever looked at, I think, a younger adult versus an older in terms of how robust the response is. Just anecdotally, I've done some surgeries and have not noticed a big difference in terms of the age, in terms of their activation, but I think it would be valuable, as you said, to look at aged mice and see if their response is any different.
And you're obviously finding some very exciting new pathways and so forth and understanding mechanisms. We also know, I guess, the pathophysiology of cervical and thoracic, SCI is a little bit different in things. And I know you've obviously only looked at cervical, but do you think there would be any potential differences and effects of what you've been looking at if you were to explore like a thoracic model?
Yeah, that's an excellent question. I think most of the literature up until this point have done thoracic. and they've described it. And so because we kind of had this more novel cervical model, all of this work is new in terms of comparing it. I think just given the difference in vasculature, more heavy vasculature in the cervical, more motor neurons, it's possible the response could be a little bit higher in cervical just because the injury environment has a lot more effects if there is a stroke or whatnot. So just because of the dependence of all the neuronal populations on that, but again, something to look at in the future.
Okay, terrific. Just no other questions. Thank you very much, and we'll move on to the next presentation. Okay, so the next presentation will be delivered by Dr. Anne-Marie Versteg. She's in the Division of Orthopedic Surgery. She completed her MD PhD and has continued on with a lot of her research in the area of spinal metastasis, and she'll be speaking to us in terms of patient expectations with this condition. So thank you.
Awesome. So hi, my name is Anne. I'm one of the PGI3 orthopedic residents here in Toronto. Thanks to Dr. Yee and Dr. Failings for the invitation to present my work that I've done over the last couple of years. It's a bit of softer science than we just heard about. So my disclosures is that this research was sponsored by a grant provided by AO Spine International. So I think we can all agree that over the past decades, we've seen this come across news, but also in our own training, that patient-centered care and healthcare quality have been trending topics as a global insight. So if we then talk about quality of care, and if we look at our perspective, like how do we as doctors and policymakers define quality of care, if you look into the literature, we talk about care that is safe, that is cost-effective, efficient, equitable, timely, and patient-centered. However, the issue with this perspective is it's the doctor's perspective and the policymaker's perspective. If we ask patients, how do they define quality? Do they care about observed versus expected post-op mortality? Do they care about the wound complication rate? Personally, no. Patients know what they experience and if they are satisfied, yes or no. They don't care if they have percentage chance for a complication. So if we simplify the patient's perspective for quality of care, is that we can look at it if a patient is satisfied with the care they got. And their satisfaction is influenced by the experiences, but also by the expectations where they start off with. So to give you a bit of an overview how this works, assume that we have two different patients, patient A and patient B. They're actually exactly the same in terms of condition, in terms of the sort of treatment that they need. The only difference between the two patients is their expectations. Patient A is very optimistic about the treatment he is receiving, and patient B, a bit less optimistic, a bit lower expectations. If they then undergo the exact same treatment, and objectively they get the exact same outcome, there is a difference. Because for patient A, actual reality is lower than his expectations, and for patient B, reality is exceeding his expectations. So logically, if you think about it, patient A is not going to be so happy because his expectations are not met, versus patient B will be happy because his expectations are actually even being exceeded with the outcome. So we know this from literature in the orthopedics department from patients undergoing total hip and total knee prosthesis, that it works like this, partially. But the problem with patients with spinal metastases is that they're different than our ordinary orthopedic patients or neurosurgery patients undergoing degenerative procedures. Patients with spinal metastases, they receive treatment, but the treatment intent is palliative. They have a different life expectancy than our normal patient populations, and they also might have different values than our normal patient population. So communication with these patients is absolutely key. So historically, when we look into the literature for patients with spinal metastases, we all published about how is their post-op survival, how is their post-op complication rate. And then over the last 2 decades, we actually changed this perspective in terms of like, let's ask the patient how they're doing. So look at patient-reported outcomes. So over the past decades, it's like a rapidly influx of papers reporting about patient-reported outcomes for spinal metastases. And we've seen that by doing surgery or surgery combined with radiation or radiation alone, we do have a significant positive impact on their quality of life. If we then look at patient satisfaction for patients with spinal metastases, we actually see that between 77 and 84% of the patients are actually satisfied with their treatment and their treatment outcomes. So factors that are associated with dissatisfaction post-treatment, and this is treatment either with radiation therapy alone or with surgery combined with or without radiation therapy, is that they had lower functional scores at baseline, lower social functioning at baseline, and also patients that are being discharged home without support. But what about patient expectations in patients with spinal metastases? Actually, this is currently unknown in the literature. But if you want to measure expectations, how do we measure those? So there are instruments out there in the literature that measure patient expectations, but then if you look at the quality of the instruments, actually more than 80% of these instruments are all non-validated. So what are we actually measuring with these instruments? So that's when the PEPSO project came into effect, is that we want to do a qualitative research project on patient expectations and the perceptions in patients with spinal metastases. So the primary objective of this study was to develop a questionnaire so that we could assess patient expectations regarding their perceptions and expectations regarding outcomes of surgical and or radiotherapy treatment for spinal metastases. And then the secondary objectives of this project were to obtain an in-depth understanding of patient expectations related to these outcomes, but also actually to explore how healthcare professionals actually verify patient expectations. So what we did is we did an international qualitative study done in Europe and in Canada. For people that are not really familiar with qualitative research, is that we interview patients and we interview healthcare professionals. And we interviewed patients before surgery or before radiation therapy and approximately 6 weeks after. And when you start off with qualitative research, there's no preset sample of patients that you're going to include, because you keep on going until you have data saturation, basically until you don't get any new information from your interviews. Then what you do is basically you transcribe all the interviews in a verbatim manner, and then you analyze those transcripts. So then the first study we published is about what we did with the healthcare professionals. So we interviewed spine surgeons, but also radiation oncologists, medical oncologists, physiatrists that are all involved in the healthcare process of patients with spinal metastases. And we asked them about, okay, so what do you tell your patients? And do you verify patient expectations? And how do you do that? So interestingly enough is that physicians say yes, we do mention that the treatment that we're giving is palliative and it's not about curing your cancer, but they actually also question, do patients really understand what palliative care means? And this is interesting because we know actually from the general oncology literature that about 70% of stage 4 lung cancer and colorectal cancer patients believe that there's a chance for cure if they are undergoing palliative chemo or radiation therapy. Then the other thing about prognosis. Radiation oncologists and spine surgeons said, yeah, we do not really discuss prognosis with their patients because they don't feel comfortable talking about it, because they don't know necessarily enough about their prognosis, and they say it's the responsibility of the medical oncologist. But then interestingly enough, if you ask the medical oncologist, they're like, well, yes, we do talk about it, but not in that much detail. So there's quite a bit of a discrepancy there. But then if we ask them about, okay, what do you think about is the importance of expectations? Basically, everyone said it is important that patients have realistic expectations and it influences their perceived outcomes. But then we ask them the follow-up questions, okay, but then do you ask patients about their expectations? And they're like, well, actually, no, we don't. And then we ask them, okay, but how do you manage patient expectations? And they're like, yeah, we manage them, but by providing really broad and non-specific treatment outcomes. So then the next study we did is we included patients with spinal metastases and also their relatives. We interviewed them pre-treatment and post-treatment about their expectations of the treatment outcomes. And pretty much in line with what we found in the physician interviews is that they feel not or minimally informed about expected outcomes. They do expect significant improvements in pain and daily functioning, but they have this at a wide range of recovery times. Some of the patients told us, well, basically, I expect my pain to be completely gone the day I leave hospital. And this could be post-op day 4, and some of them are like a bit more realistic, saying, okay, this might take maybe a month or 2 months, but this shows like how wide the expectations vary between patients. And patients also said that physicians are their main source of information for expectations. And they say, in line with what we found in the interviews with physicians, is that life expectancy nor the impact of treatment on life expectancy was discussed with them. So when we then asked them about life expectancy and cure, is what we said is it was not discussed, but there was also differences in expectations. There was a significant proportion of patients that thought that the radiation treatment or the surgery was actually going to give them a chance for cure of their cancer. And that's actually very important to realize, because we know from also the general oncology literature, if patients have the feeling that there's a chance for cure, they are willing to accept a 10 times more likely invasive source of treatment than if they know if it's not going to, if there's any chance for cure. So was this all negative? No. Patients do feel they're very well informed about the procedural aspects, like what's going to happen in surgery, what's going to happen with radiation treatment. But they also say, I'm overwhelmed by the information we are getting. And patients do feel it's a shared decision-making process. So, okay, so we have all this information from the interviews with physicians and with patients, and how do we go from there to a questionnaire? So what you then do is basically all these informations are analyzed and grouped into teams and sub-teams and topics, and then based on those identified topics, you start developing items. And then those items were then subjected again to patients for relevance, for face validity, content validity. Patients are asked, do you understand the question we are asking? Do you find the question relevant that we are asking? And then basically you work through this iterative process, and then we come up with the final questionnaire. So based on all the feedback from all the patients, we developed 2 different versions of what we call the PEPSO questionnaire. One is mainly targeted for surgical treatment, and the other one targeted for radiotherapy treatment. The questions are exactly the same, it's just the framing of the answers, and that is different, and that improves readability and understandability for the patients. The questionnaire is divided in 3 different parts. First, patient expectations of the treatment outcomes, then part that assesses the expectations of prognosis, and also actually a different part that is evaluating how satisfied patients are with consultations with their spine surgeon or their radiation oncologist. So this is basically a snapshot of the new questionnaire for part A. We asked them about, okay, what do you expect regarding the pain in your back or neck after treatment? Is it going to change, or do you actually don't know? And then the next question we ask for the same question is, when do you expect this treatment? Because it's important to realize if the patient expects this to happen like within a very short time frame, or if you need to tell them, hey, no, this is going to take a little bit longer. So that's the added benefit of adding a time frame in there. Then for the prognosis part, we are asking patients, okay, what do you expect that this surgery or radiation treatment is going to give you? Is it going to help you with reducing pain, or do they believe it's going to improve their chance for cure? If that's the case, you can go back to your patient, talk to them saying, hey, you think there's a chance of cure with the treatment I'm giving you, but that's actually not the treatment intent. Realign this expectation. And then the last part is evaluation basically of the consultation. Do patients feel that they understand the information that was provided? Do they understand the reason for the surgery or the radiation treatment? Do they understand the risks of treatment? If they say no or they do, you can, again, go back and talk to them again. So putting everything together, I think for patients with spinal metastases, but in general, we should go for the VIP approach, the very individual patient approach. We should focus for every patient on the risks, the benefits, and the outcomes for this specific patient that is in front of you. And care should be focused not only on physical comfort, but also on the emotional well-being. That's especially important for the patients with spinal metastases. And it's important to give them more information and the correct information they need. So hopefully this new PEPSO questionnaire will help us to systematically evaluate patient expectations. It will help us understand individual patient preferences and expectations. By understanding those preferences and expectations, we are able to inform patients on a patient level, and we can modify their expectations if needed, and hopefully in the end improve patient satisfaction and patient outcomes. Thank you so much.
Dr. Failings?
And thank you. Excellent presentation. It's important work. This is a complex patient population to deal with. And, you know, perhaps could you comment on the challenges that we might face with two scenarios that maybe weren't reflected in your talk? One is the difference between encountering a patient in the emergency room that's coming to you emergently versus electively. And secondly, the issues with the multicultural environment. We live in a city where over 150 languages are spoken. Not everyone shares, even in this room, people are coming from different cultural backgrounds and have different views on how they interact with the healthcare system.
Yeah, thanks, Dr. Failings. Yeah, absolutely excellent questions. So first addressing the second part of the question. So we have this new questionnaire right now. This is the first phase of development, so this questionnaire still needs to be validated, so that is the next step that is being done. And that includes the cross-cultural validation, so that is a very important aspect. In the original study, we did make sure that we have patients from different cultural backgrounds. We didn't find a difference there in terms of like the opportunity to talk about prognosis, because we know actually that it might be a difference, but we didn't find that difference actually. So hopefully in this validity study, we will maybe find differences. And that's another thing that we also want to do is, of course, we have to translate it also to the States, because the questionnaire was developed in Europe and in Canada, where we have this public healthcare system that is not influenced by financial decisions, which might also influence patient expectations. And so that's the other thing we have to assess in this validity study. For the first question about the emergency patients, that is definitely a challenge. I think the main question there is we should ask, like, are patients willing to accept a very invasive treatment if they know it's not going to cure the cancer? Because I think that's, for the majority of patients, still a driving decision-making factor. And I think that's something we have to stress, especially in the emergency department. That's a clear goal of surgery, is not to cure the cancer, is really to improve quality of life. But managing or realigning those expectations in that acute setting is definitely going to be challenging. Yeah, for sure.
Dr. Ramprasad.
Hey, and great work. Thanks for that. To follow up on that last point, on your questionnaire, it says you have a prognosis section. But when you're interviewing patients, do they actually truly understand what that means? And it kind of ties into this curative, non-curative. Our operational definition of prognosis may be very different than that of the perspective of the patient. So I'm just wondering how you deal with that in the questionnaire. Do you have a case definition or an example for them to help them understand what it is you're asking as it pertains to prognosis?
Yeah, so in the questionnaire, it's really about, like, we're asking them about their life expectancy. So really asking about, okay, initially in the original questionnaire, we actually had the question about, like, in terms of months, but we got feedback from the patients, not surprisingly, that was too confrontational. So we removed that question based on the feedback from patients, and then we replaced it with the question of the chances of cure, and if the proposed treatment is going to influence the chance of cure, and if the goal of surgery is cure. And based on all the feedback from the patients is that they clearly understood the question we were asking, and they clearly understood also what we were meaning by life expectancy, because it was discussed previously by the medical oncologist.
Thanks.
Okay, last question, Dr. LaRouche, and then we'll move on.
I'm happy to, I've harassed Dr. Versieg plenty of time. I'm happy to pass the last question.
Thank you. I have a question. When you interviewed the patients, were there a relative or friend with them to facilitate translation, because the patient have selected hearing, and if there's somebody else in the room, they may understand something a little bit different or more clearly? Was that a factor as well?
So we used, so for the interviews, we had patients that they wanted the relative to be there when we did the interviews, but some patients preferred not to. So there's a combination of patients in there. But we also really try to make sure that we did also like a pilot trial with the interviews to make sure that we are asking them in a manner that they could clearly understand. And we were also asking like really follow-up questions to make sure they understood the question and that kind of stuff.
Thanks.
Okay, thank you very much.
Thank you.
So our next presentation will be given by Dr. Aditya Raj. He completed his orthopedic training in India. He is a fellow as part of the citywide program at the Toronto Western Hospital, and he'll be speaking to us on sex, drugs, and spine surgery.
Okay, good afternoon, everyone. I'm going to be talking about an interesting topic, sex, drugs, and spine surgery, which is a nationwide analysis of opioid utilization and patient-reported outcomes in males and females. I'd like to acknowledge all my co-authors and thank Dr. Ramprasad for this opportunity. And I'd also like to thank the entire team for SpineFEST for allowing me to present this. My colleague, Dr. Cherry, has previously laid some groundwork for this, so I'm trying to build up on that. I don't have any relevant financial disclosures for this. And the study focuses only on biological sexes as opposed to genders, which is a psychosocial concept that does not necessarily match sex. So literature shows that females have different pain perception and response as compared to males. Females are more likely to report worse pain outcomes, worse pain scores, and they are usually likely to be prescribed more opioids. Studies comparing sex difference in chronic pain conditions in spine surgeries have shown that there's greater pain prevalence among females. And there's some preliminary evidence that this difference might appear due to multiple cellular and molecular factors. So if we look at this preliminary literature that supports this kind of a difference, we look at this study about the physiological responses in males and females, healthy males and females when they are given pain stimuli, and then we see the endogenous opioid receptor activation in the brain. And they found out that in females, this was likely controlled somewhat by the levels of estrogen, and higher levels of estrogen was responsible for better endogenous opioid activation. Similarly, on the molecular level, they found out that in response to sciatic nerve injuries, in females, this pain pathway and pain response is more controlled by T cells as compared to males, where this is more controlled by microglial cells. And finally, the genetic predisposition that shows that some of the genes that code for ZIST RNAs and YY1 RNAs are likely found in patients with chronic musculoskeletal pain and post-traumatic stress symptoms, and these are more likely and commonly found in women as compared to men. So that forms the rationale for our study. So chronic pain and opioid use are usually associated with poor patient outcomes, hence potential sex differences should be identified. Studies focusing on sex difference bias and opioid use specific to spine disorders are sparse, and the results in these are rather inconsistent and often report no significant difference in opioid use. So this study may help us to begin to bridge the knowledge gaps in the understanding of patterns of opioid use and surgical outcomes among males and females. So the primary objective of the study was to identify any preoperative differences in opioid use between males and females, and also to identify factors associated with baseline opioid use and impact of baseline opioid use on patient-reported outcome measures at 12 months post-op. So this is a retrospective review of CSON data from January 2015 to September 2022. And the data collected included patient-reported measures, social demographic factors, lifestyle factors, and perioperative procedural information. We then did a univariate and multivariate analysis stratified by sex, and then logistic regression was performed to identify independent factors associated with baseline opioid use. So the first objective of the study to identify any potential sex differences. Our data included 5,152 patients with at least 12 months follow-up. 52% of these were opioid non-users and 48% were opioid users. Males comprised slightly more, about 53% of the entire cohort. And we found out that among males, 44.5% were likely to be opioid users as compared to females, which is about 51.7%, and this difference was statistically significant. Similarly, amongst the opioid non-users, they were more likely to be male, about 56%, as compared to females, about 43.8%. This is a bit busy in terms of, the slide is a bit busy in terms of the details we want to convey, but more or less, if we look at the entire cohort, we find out that lower age, higher BMI, more comorbidities, thoracolumbar location of pain, preoperative tobacco use, patient on claims, and higher PHQ-8 scores were associated with a higher baseline opioid. In terms of the cohort analysis of females, the factors remain pretty much common, but there are three important factors which show maximum difference, and that is patient on claims, not working and not exercising pre-op associated with a higher baseline opioid use. And this difference was similarly more significant in males as well, the same three factors. And if we look at the difference of factors amongst the entire cohort versus males and females, we found out that smoking amongst males was more likely associated to be with higher opioid use. Similarly, education status less than high school among males, and spondylolisthesis as diagnosis among females. Once we did a regression analysis, we found out that the factors from the previous table were pretty much consistent. Younger age, more comorbidities, thoracolumbar location of pain, not working, not exercising, higher PHQ-8 scores, and disc herniation and diagnosis were associated with higher baseline opioid use. And once we tried to find out the different factors for males and females, we again found out that smoking was much more important in males, and exercise status was much more important in females associated with higher baseline opioid use. Similarly, disc herniation as a diagnosis among females was also consistent with higher baseline opioid use. The second part of our objective was to find out the improvement in patient-reported outcome measures. So we looked at the numerical scores for back and neck pain, leg pain, ODIs, NDI, and SF12, PCS, MCS, and EQ5Ds. And we found out that regardless of sex, opioid users and non-users both showed significant and similar degrees of improvement in patient-reported outcome measures at 12 months compared to the baseline. We also did an adjusted analysis, trying to adjust for age, BMI, comorbidities, PHQ, and smoking status. And we found out that opioid users were slightly they had slightly worse patient-reported outcome measures, especially among males for NRS, back and neck pain, ODI scores, and EQ5D. The difference in the scores was not clinically very high, but this was significant. So to conclude, preoperative opioid use was significantly higher in females as compared to males. Most baseline factors associated with higher opioid use were common between males and females. Patients on claims and those not working preoperatively were significantly high risk of baseline opioid use, regardless of the sex. Male smokers and those with education status less than high school were again at higher risk of opioid use. And not exercising was an important factor associated with higher use, especially among females. And there was a small but significant difference in NRS for back and neck pain, ODI and NDI in males, in opioid non-users as compared to opioid users. There are certain limitations of the study. The first is it's a retrospective analysis. The second and important is these are patient-reported opioid use. So they may actually underreport the actual use as compared to the prescription-based opioid use, which is generally overreported. And we did not report opioid dose data in the study. The most important strength of the study is that we do demonstrate some important sex differences in independent baseline factors associated with opioid use. And we have a very large sample size across multiple centers nationwide. Future directions, we do need further investigations to determine interactions by sex and confirm these important differences. And hopefully when we do have those, we can develop some sex-specific mitigation strategies in the perioperative period as compared to broader risk factors. And we should always remember that pain is a multifactorial response. Physiological, genetic, molecular, and psychosomatic factors do play important roles, so we maybe need to dig deeper into these factors and try to come out with strategies specific to each. Thank you.
Dr. Amendolia?
Great presentation. Were you able to look at the duration of opioid use and compare that, whether or not that made a difference in your outcomes? Was it for 1 week, 2 weeks? Was it 5 years?
We don't have the exact data of how many patients were using opioids for a specific duration and the dose at the moment.
Hi, it's an interesting study. You mentioned that women who do not exercise have a higher opium use. Do they not exercise because they have pain? Or is it have been reported they didn't exercise and then they took more opium?
It's difficult to predict what's the reason for not exercising preoperatively. It may be because they're in pain and that's the reason, and that's why their opioid use was high, so that may be, but it's difficult to comment if that's the only reason.
But would that then indicate that males don't have as much pain preoperatively, or they're not using opioids? Or?
So we did not actually measure that in the current study, but there have been studies in the past that show that females tend to have worse pain scores to start with, and then they are offered surgical intervention at a pretty later stage as compared to males, but that's a part of a different study.
Okay, thank you.
Thanks.
Nadia, was there a question online, or is that from earlier? Okay. Other questions? Okay.
Thank you.
Thank you very much. Okay, so the next presentation will be given by Dr. Sri Kandaraja. He completed his neurosurgical training in the UK. He's currently completing clinical fellowship at the Toronto Western Hospital and will be speaking to us on prevention, diagnosis, and management of intraoperative spinal cord injury in the setting of spinal surgery.
So my name's Nish. I'm a fellow at Toronto Western, and I'd like to talk today about prevention, diagnosis, and management of intraoperative spinal cord injury in the setting of spine surgery, for which we developed guidelines and an evidence-based care pathway. I'd like to acknowledge my co-authors, Nader, Ali, Alvi, and Aisha, and also the senior authors, Dr. Kwan in Vancouver and Dr. Failings here. So, intraoperative spinal cord injury.
Code white in P2, first floor. Code white in P2, first floor, South building. Code white P2, first floor, South building.
I'll finish off the introduction. So, intraoperative spinal cord injury is a challenging complication in spine surgery. Intraoperative neuromonitoring is something we use to detect these changes, and in the literature there is a lack of guidelines when it comes to intraoperative spinal cord injury definition, incidence, diagnosis, prevention and management. So this was a multidisciplinary international effort using members from AO Spine and Praxis as well, and we used the GRADE methodology, which I'll go into later. So imagine this as a case example. And if you have a checklist for this, really, and this is more for probably the residents and fellows and early years surgeons, as opposed to the more experienced staff in the room. So imagine a 60-year-old primary care physician comes into your clinic and says, look, I've got a lot of numbness and tingling in my arms and hands, non-dermatomal distribution, finding it difficult at work in terms of dealing with this now for the past few months. And you do some imaging and you find this in his MRI scan. What's your strategy? What's your plan here? So he's got an enhancing nodule, and then on the T2 he has a lot of edema here. So in terms of management, we had discussed with him everything that had been shown on the imaging. We did a full neurological examination. We did discuss this case with other spine surgeons in the multidisciplinary team setting. And then we essentially explained that he would need to have an operation for this to remove the lesion. We take him to the OR, and you inform the whole team that this is a high-risk case. You have neuromonitoring available. You position him prone safely with a Jackson flip. You doing the myelotomy, and essentially when you're manipulating and taking the tumor out, the intraoperative neuromonitoring team tells you, hey, we've got a drop in the left FDI. So think about what you would do at this point. And I'll come back to this at the end. So our aims here were to develop a definition of intraoperative spinal cord injury, find out the high-risk cases in the literature, quantify the incidence and risk factors, establish sensitivity, specificity, and accuracy of intraoperative neuromonitoring modalities for detecting intraoperative spinal cord injury, and also gain a consensus over its use in high-risk cases, and develop an evidence-based algorithm for it. We did a mixed methods approach, registered on Prospero, and performed according to PRISMA guidelines. 3 literature reviews. First one, looking at definitions, frequency, and risk factors. Over 200 articles identified, 7 included. Then we did a diagnostic test accuracy meta-analysis to look at the use and accuracy of intraoperative neuromonitoring. And that had over 160 studies in just under 100,000 patients. And then we looked at the different management approaches of intraoperative spinal cord injury in the literature, and found 17 formal checklist algorithms, which we identified for analysis. Then the results of these reviews were put forward towards a consensus session using the grade approach, with an 80% threshold for inclusion, to decide the definition for intraoperative spinal cord injury and recommendation of its use in high-risk cases. Now, why did we use the grade methodology? So in the old system, if you've got an observational study, that's got a lower level of recommendation, as opposed to an RCT, which would have a high level of recommendation. But then what grade does is it takes quality of evidence into consideration, resource use, patient values and preferences, and the balance between benefits, harms, and burdens. And you can essentially upgrade an observational study or downgrade RCT, so it's seen as fairer. So for the first part, we decided on a definition for intraoperative spinal cord injury, and this was after a systematic literature review, a priori definition, a grade evidence to decision framework, and a consensus meeting through AO Spine and Praxis. And that is a new or worsening neurological deficit attributable to spinal cord dysfunction during spine surgery that is diagnosed intraoperatively via neurophysiological monitoring and or wake-up tests, or immediately post-operatively based on clinical assessment. The reported incidence of deficits in the literature is higher for intramedullary tumor resection, which is at 0 to 61%, with more persistent deficits, as opposed to deformity surgery, which is ranging from 0 to 17.8%. And then in terms of what's listed as high-risk categories in the literature, they're generally low-level evidence retrospective papers, but this is what's listed out there, is high-risk deformity, revision congenital deformity with significant cord compression and myelopathy, an extrinsic lesion with cord compression and myelopathy, intramedullary tumors, unstable fractures, and extension destruction injury with ankylosing spondylitis, and OPLL with severe cord compression, which is moderate to severe myelopathy. And then the next stage went on to the diagnostic test accuracy meta-analysis. And essentially you can see here for all types of intraoperative neuromonitoring, multimodal, for the diagnosis of intraoperative spinal cord injury, if you look at the yellow, you can see that they generally, if you use all of them, they have a high sensitivity and high specificity of detecting an issue. And then if you subdivide up the different types of operations you're doing, if it's degen, deformity, tumor, mixed pathology, they all generally have a high sensitivity and specificity. Now, in terms of this is a ROC curve, but what I want you to just look into is basically the y-axis is sensitivity, and you want it to be high sensitivity, but also the x-axis is the false positive rate. So this is what surgeons hate. So essentially, if you get something like an alert in the OR while you're operating and it's not actually a real alert, you spend a lot of time having a lot of stress trying to get rid of it. And also you're trying to do reversal maneuvers, which is not really needed. So you don't want to have a high false positive rate, you want to have it low. And you can see that the summary statistic, which is in blue, essentially shows that if you use multimodality intraoperative neuromonitoring, you have a low false positive rate and you have a high sensitivity, which is exactly what you want as a surgeon operating. And then we, on our next stage, we looked at all the checklists out there and essentially made up one ourselves, which we adapted from Vitale in 2014. And we divided it into 3 sections: surgery, neurophysiology, and anesthetics. So if you get an alert in the OR, this is the checklist we would recommend you go through. So in terms of surgery, you want to make a pause and announce to the team there's an issue happening here. You want to eliminate any external distractions. You want to discuss which events happened prior to this intraoperative neuromonitoring change, and thereby you might go ahead in the OR and do decrease and remove traction, remove rods, open close osteotomies, widen the decompression. And obviously it's a tough situation to be in, so it's good to call upon your senior colleagues at this point if they can have a fresh view. And then in terms of neurophysiology, you want to check the status of the anesthetic agents. You want to look at the attributes of the signal and not just treat it as, oh, there's a change. You want to see if it's asymmetric or it's symmetric, because that can essentially show you, is it a regional systematic problem or is it a focal issue because you've accidentally gone a bit too hard with the kerosene. Check electrodes and leads, rule out electrical interference, adjust stimulation parameters. This is what your neurophysiology team will be helping you do. Repeat testing at shorter intervals and check that the patient's appropriately positioned. Anesthetic factors, you want to make sure you optimize the anesthetic agents, and you're conversing with the anesthetic team at this point. You want to optimize your blood pressure, your hemoglobin, your blood volume, oxygenation, ventilation, and PCO2, and ensure normal thermia and check the blood glucose and electrolytes. And if there's ongoing issues, then you want to think about a wake-up test at this point, and maybe with consultation with a colleague, you may want to think about staging the procedure or aborting it. Think about giving IV steroids and using imaging if required. So in terms of dealing with high-risk cases and also dealing with intraoperative spinal cord injury, it starts before you taking the patient to OR. So in terms of the initial step, you see the patient in clinic, like we did in the first case, and you identify them as high risk. You document an accurate neuro exam, and you do an informed consent with the patient. Step 2, you do your pre-op planning. So multidisciplinary team meeting, plan on using intraoperative neurophysiology, and also agree on a checklist for management, whatever that may be, and have a monitored bed available if you think it's that high risk. Surgical planning, well, if it's a cervical issue, you want to have fiber optic intubation for an unstable C-spine. You want to maintain your MAP targets, intraoperative neurophysiology monitoring, and patient positioning. Image guidance, step 4, we went through the checklist. And step 5, post-operatively, you want to make sure that the patient's in a monitored bed. You document serial neurological examinations. You maintain their MAP parameters. Maybe consider even pharmacological intervention with methylprednisolone, and consider the need for post-op advanced imaging. Now you know the checklist. You feel much better dealing with these kind of issues. So you get this issue, and we have this in OR. So at the time, you stop what you're doing. You tell the team, this is what's happening. You put some saline in the wound. You take a break. You discuss with the anesthetic team regarding increasing the MAP, maintaining normothermia, and then probably repeat testing in about 5-10 minutes, which is what we did, and this had resolved by itself. And then afterwards, taking consideration this has happened, you take a more cautious approach, remove all of it. This patient ended up in a level 2 bed afterwards for 24 hours and had no focal deficits and was discharged home. So in conclusion, this is the first evidence-based comprehensive guideline and care pathway for prevention, diagnosis, and management of intraoperative spinal cord injury using this GRADE methodology. hopefully this will facilitate a reduction in the incidence of intraoperative spinal cord injury and improve outcomes. And we're hoping that this can be validated through prospective multi-center studies and welcome this. So thank you very much, SpineFEST, for allowing us to present this.
Okay, terrific. Questions from the audience? I guess in terms of your next phases of knowledge translation, knowledge transfer, and then I guess in terms of the utilization sort of in practice, it varies a little bit depending on jurisdiction. And, you know, in some places there's, even with centers that have neurophysiological monitoring, sometimes there's some prioritization and availability of those sort of resources. There's also some of those automated machines. And so I guess, you know, how do you think about the logistics in terms of the practicalities alongside, you know, obviously the guideline KT part of things?
Yeah, no, we appreciated that not everywhere has the availability of intraoperative neuromonitoring to be used for you know, all cases indiscriminately, and hence why we suggested a high-risk table which we developed.
Code white, all clear. Code white, all clear. Code white, in situ, all clear.
That's a relief, it's all clear now. So yeah, definitely we would essentially want to have it used for those high-risk cases, but that's not a be-all and end-all. There's other cases that can be added on if need be. In terms of dissemination, we're presenting it in other places, and hopefully this will go for a focus issue in Global Spine Journal as well. And in terms of the checklist, we're wanting it to be used kind of in the OR to be put up. And we have suggested a care pathway, but obviously, as you suggested, due to institutional policies, people can kind of edit that according to their requirements. So hopefully, I'm going back to the UK, and I would like to use this. And I think if we have such a strong fellow group, if people start disseminating it out from here, that would be great.
Okay, terrific. Thank you.
Thanks.
Okay, so the next talk will be on the safety and efficacy of riluzole in acute spinal cord injury. Dr. Mohad Damaju will be presenting. He is a neurosurgery resident, completing his PhD under Dr. Failings. Thank you.
Thank you. My name is Ali. I'm one of the neurosurgery residents, currently doing a PhD under Dr. Failings. It's an honor to be here today on behalf of the RISCUS investigators to share the results of the RISCUS trial, which is a multi-center randomized placebo-controlled double-blinded trial studying the efficacy and safety of riluzole in acute spinal cord injury. The principal investigator was Dr. Failings, and this study was mainly sponsored by AO Spine and the U.S. Department of Defense. And the results of this trial were actually published last week. So I have no commercial disclosures. So the RISCUS trial is an international trial with 23 centers across Canada, the United States, and Australia, with the primary site being here in Toronto. So the agent being studied is riluzole, which is a sodium channel blocking agent, which blocks the exotoxic release of glutamate following traumatic spinal cord injury. Riluzole is currently FDA approved for the treatment of ALS, and it's known to be quite safe clinically. There have been numerous preclinical trials which showed evidence towards neurological recovery in the context of spinal cord injury animal models. And this led to a phase 1, phase 2A trial in 72 patients, which not only demonstrated safety with the use of riluzole in traumatic spinal cord injury patients, but also showed some early results towards neurological benefit. As seen here in this graph, patients who were treated with riluzole after 200 days on average had a gain of 56 motor points compared to 52 on the placebo group. So these results, compared with the results of the preclinical models, led to justified the RISCUS trial, which again was an international placebo-controlled trial. And the dose that was given was 100 milligrams twice a day for the first 24 hours, administered orally, followed by 50 milligrams twice a day for 13 days. In terms of the sample size calculation, so this was an adaptive trial design. In order to pick up an effect size of 9 in the total motor score, the sample size that was calculated was 324. The primary endpoints were measured at 6 months, and they included the change in total motor scores as per the Asia assessment, as well as change in the upper motor scores at 6 months. Some of the secondary endpoints include other aspects of the Asia assessment, including the lower motor score, the Asia grade, and the neurological level. We also looked at some of the functional measurements with the spinal cord independence measure, the EQ5D index, SF36, as well as the GRASS measurement, which is a very specific measurement of hand function and strength. In terms of the inclusion criteria, all adult patients between the ages of 18 and 75 who had a cervical level of injury defined to be between C4 to C8 and an Asia A, B, or C were considered for enrollment. It's important to note that this trial was in the acute phase of injury, so patients who were able to get the studied medication within 12 hours of injury were considered for enrollment. In terms of exclusion, any severe distracting injuries such as concomitant TBI as well as penetrating mechanisms were excluded, as well as previous history of spinal cord injury. So now I'll go over some of the results. So the RISCUS trial was actually halted during the ongoing pandemic in March of 2020 and eventually stopped in September 2021. This decision was made by the sponsor, and this was around the peak of COVID where no recruitment was possible, and this was independent of the results or the interim analysis. Despite this, 193 patients were recruited with an almost 83% follow-up rate at 6 months. Which makes this one of the largest trials in spinal cord injury since the Cygen trial, which was almost two decades ago. In terms of the demographics, the two groups, the placebo and Riluzole group, were statistically similar. The average age in the control group, placebo, was 47.6, and the average age in the Riluzole group was 49.4, and this is showing the changing trends of spinal cord injury towards more older patients. In terms of the injury characteristics, the patients that were part of this trial had pretty severe injuries, as the most common Asia impairment scale was A, within 52% of the patients, and they also had, on average, higher level of neurological injuries, as the most common level of injury, neurological level of injury, was a C4 injury seen in 54% of the patients. So here are the results of the primary outcome. On average, patients who were treated with Riluzole had a higher gain in total motor and upper motor scores, as well as lower motor scores. However, the increased gain seen did not reach the pre-specified statistical criteria for superiority. As we can see here, the 95% confidence interval does cross the threshold of 0. So more specifically, at 6 months' time, patients who were treated with Riluzole had an average gain of 34 points compared to an average gain of 31 points in the placebo group, which the mean difference here is almost 3 points with a p-value of 0.28. So now I'll discuss some of the secondary endpoints in the subgroup analysis, which have been recognized to be of increased importance through the conserve guidelines in trials that were stopped during the COVID pandemic, which there are some estimates that there were over a few thousand trials that were actually stopped at this time. So looking at the Asia A group specifically, there was an average gain of 0.5 neurological levels in the Riluzole group compared to an average gain of 0.12 in the placebo group, and the p-value here was 0.08. The most effect was actually seen in the Asia B population, and they were mainly in the functional measurements. So there was a statistically significant gain in total SCIM score, so that's the spinal cord independence measure, SF36 and EQ5D subscores in the Asia B group. Specifically, at 6 months' time, patients who were treated with Riluzole had an average gain of 45 points in their total SCIM score compared to an average gain of 27 points in the placebo group, and this 18-point difference was statistically significant with a p-value of 0.36. Similar effects were also seen in the subgroups of the SF36 and the EQ5D measurements. We do see that also in the Asia C subgroup, there was a statistically significant gain in motor scores in the multivariate linear regression models in both the upper and the total motor score. In terms of the safety evaluation, there was no difference in adverse events with the administration of riluzole compared to placebo, confirming the clinical course that we've seen with riluzole in the ALS population. So overall, despite the early termination of the trial, 193 patients were recruited, and there were some trends in favor of riluzole in the primary outcomes, but this difference did not reach the pre-specified statistical criteria for superiority. There were positive signals, however, seen in several of the pre-planned subgroup analyses. As discussed, there was a higher mean gain in the neurological levels in the Asia A population. In the Asia P population, we saw superior gains in some of the functional, statistically superior gains in the functional measurements, such as the spinal cord independence measure. In the Asia C population, we saw increased gains in the multivariate analyses. So moving on to some of the interpretation of these results. So given the lack of alternative treatments for traumatic spinal cord injury, there may be a lower threshold for accepting a higher false positive rate with administration of neuroprotective agents. This is particularly given the fact that conducting these trials is quite challenging. The results of this trial should be considered by guideline committees to put them into context when it comes for the treatment of spinal cord injury. There are also several lessons that we can gain for future trials. For one, spinal cord injury trials are time sensitive, and they're trying to measure a very heterogeneous group, and spinal cord injury fortunately is relatively uncommon, and these factors make studying spinal cord injury quite challenging. And we do need to address some of the heterogeneity that we have in the patients, and we also need to come up with better outcome measures that are clinically relevant, and we need to come, for example, we do not even have a minimally clinically important difference that's well established in traumatic spinal cord injury. Perhaps we can look at the treatment for other orphan disorders and learn some lessons from them. These include like ALS, Parkinson's disease, and some of these conditions, they've used some unique trial designs with virtual controls, and they have eliminated placebo arms. And there's also some unique methods with multi-arm, multi-stage trial platforms. And all of these methods allow to decrease the sample size and allow us to also study multiple agents at the same time. Thank you very much.
Any questions? I think this sort of highlights some of the challenges and the impacts, obviously, of the pandemic, and there's certainly statistical observations and sort of trends, and if you sort of are able to sort of recruit your full sort of sample size, you sort of wonder what potential outcome might be, just given some of the observations that were noted. I guess in terms of potential next steps, I mean, we heard some interesting preclinical work on the role of things to sort of target, glutamate and things. Do you think there is a role to, look at a next step and maybe just sort of a prospective type of study versus completely randomized one? I guess thoughts? Michael, this is certainly something dear, and I think in and around the city and internationally, a lot of centers are trying to work together on some of these important questions in a very challenging population, as you sort of highlighted.
Yeah, so the work's now coming out for publication, and so we'll have to see kind of how guidelines groups will kind of assess the significance of the secondary outcomes, right? So in a sense, we're kind of in a similar situation that was run into with methylprednisolone, except we're presenting the results differently, right? So with methylprednisolone, the primary outcome was negative, and there was a positive result on pre-planned secondary outcomes. So this is what we're seeing. I think probably the secondary analyses here on reflection are more robust than what was seen with methylprednisolone, and probably the safety profile of riluzole is superior. So we'll have to see, right? Will it be used? I think that so I'm hoping that, guidelines groups may say, okay, this could be an option, particularly for the Asia C patients. That's one point. And then secondly, I think that there's an opportunity to either, do a repeat study, particularly in the Asia C population or to collect prospective data. And then subsequently, there may be the opportunity to run meta-analyses, right? And so, potentially with the accrual of additional, it would have to be prospective data, but with the accrual of additional prospective data, we might be able to run meta-analyses. And there is, precedent, for that when you've got studies that are underpowered. And then, we've run sensitivity analyses on this, and it was estimated that, with perhaps another 10 patients, we could have potentially achieved significance on the primary outcome.
Okay, so thank you very much. Appreciate it. Okay, so Mr. Alex Bach will be speaking on the effect of early spinal decompression on segmental neural recovery in acute traumatic spinal cord injury, a pooled analysis of individual participant data from prospective multicenter trials.
Good afternoon, everyone. My name is Alex. I'm a third-year medical student and engineering master's student at U of T. Today, I'm honored to talk about our work looking at the effect of early surgical decompression on segmental neurological recovery in an acute traumatic spinal cord injury. The presentation includes collaborative work between myself and my colleague, Dr. Ali Mogadamju, and this was supervised by Dr. Failings. I have no relevant disclosures. Traumatic spinal cord injury has been described since antiquity, with the first known writing actually in the famous Edwin Smith surgical papyrus dating back to 1600 BC, which is actually thought to be a copy from an older text originally written in 3000 BC. They basically tell us that at the time they regarded spinal cord injury as an ailment not to be treated. And after the decline of the Egyptian Empire, there are records from Hippocrates, who was the first to describe traction in order to reduce these injuries. Then we skip to the pre-Renaissance in 1230, where Roland of Palma, Italy, talked about using manual extension as a way to treat spinal fractures. And he's also regarded as the first in written history to talk about early intervention and its importance. Now we know that there's strong biological rationale for treatments aimed at stopping the cascade of secondary injury and spinal cord injury. With pharmacological and neuroprotective agents still in their infancy, the way to do that currently is with preventing hypoperfusion and early surgery. And essentially, early surgery decompressions, early surgical decompressions restores perfusion to the ischemic penumbra and thus mitigates the secondary injury. So how early is early? The most common definition of early surgery in the literature is a 24-hour threshold. And this is also corroborated by a survey in which what most surgeons surveyed considered to be their cutoff as well. So this cutoff was the definition of early surgery that we used for the project. And there's a growing evidence for the benefits of early surgery and the treatment of SCI, and this can be concluded from a culmination of research over the years, including this published last year or 2 years from Toronto, which showed clear benefits of early surgery in terms of neurological recovery in a pretty large cohort. And this growing evidence has now culminated into an effort to update a new upcoming clinical practice guideline on the timing of surgery, strongly recommending early surgery for traumatic SCI. However, there's still questions and controversies that are left to be answered. While the results are clearer for SCI patients as a whole, they have not been isolated on specific subpopulations such as Asia A, that is motor and sensory complete injuries. Furthermore, minimum clinically important differences, as mentioned in previous presentations, have yet to be established for this disease. Historically also, it has been thought that Asia A patients do not actually have the tendency to recover despite best management. So our project's goal was to focus partly on Asia A patients as a subgroup, but also spinal cord injury patients as a whole, and determine whether the impact of early surgery can be isolated in this group, as well as assess improvements using outcomes that may be more interpretable for clinical importance. So our hypothesis was that early surgical decompression improves long-term neuro recovery in patients with SCI. And as mentioned in the previous presentation, studying SCI patients is challenging, and Asia A patients especially so. One of the reasons is because, for one, we don't fully understand the natural history of Asia A patients, as evident by varying rates in the literature that's quoting different rates of spontaneous recovery. Second is that the outcome measures used for the study of SCI have yet to be associated with a clinically important difference measure. And we aim to address our questions by leveraging a combined granular database with novel methods of studying recovery, which permitted the examination of subgroups through having uniform outcome measures. So for this study, we combined various prospective data sets. This was, at the time, the highest quality data set available for acute SCI with 1-year follow-up. So to answer the first knowledge gap, that is the natural history of Asia A, we utilized what's called a multi-state model. It's essentially a survival model that assumes that a patient can be in one of several states that they can transition in and out of over time, with one absorbent state that the patient cannot move out of. If you are familiar with multi-state modeling in the healthcare literature, one of the classic examples of this absorbent state would be death. For our model, we defined it what's called a true Asia A population. And the important thing to know about this model is that unlike the cross-sectional analyses that often uses natural history, it factors time and the history of transitions, wherein the longer you stay in a transition or in a state, the less likely you're to move out of it. And this is the general kind of preliminary results over a year of follow-up. Essentially, over time, we see that Asia A spontaneously converts around 35% of the time, which is a bit higher than what's usually quoted in the literature. And our second question was on the impact of early surgery. And we picked the cervical region as is the most prevalent for Asia A patients. We included Asia A cervical patients, and of note, we also excluded patients with an abnormal GCS, our rationale being that patients with concomitant TBI with cognitive changes may likely affect an inaccurate Asia exam at baseline. And in the absence of an accepted MCID, we came up with a unique measure of therapeutic effect. We aimed to make this simple yet definitive for a benefit. So what we did was we basically tabulated the motor levels gained below the level of injury at 1 year. And we defined a significant gain as a gain of more than 2 motor levels. So to illustrate this with an example, let's take a patient who comes in with an Asia A C5 level of injury. The only function that they have is that of elbow flexion. Now, let's say a year later, this patient is now C8. They have gained more than 2 motor levels. Now they can actually use their wrist and hand. I think it's clear that this is a meaningful recovery, but if we had used Asia conversion as it is done historically in literature, this patient would not be counted as an improver, as both are Asia A patients. And here are the basic demographics of the population, and then there's just of time, I won't go through these in detail. Overall, we included about over 350 Asia A cervical patients. And in this patient, in this table, in this chi-square analysis univariately, it shows that patients with early surgery had a significantly greater proportion that experienced significant gain that is of 2 or more more than 2 motor level improvement of around 39.4%, compared to 10% less of the patients in the late surgery group. And this effect is corroborated in multivariate regression, where the outcome was the binary outcome of having a significant motor level gain, where you can see that early surgery is the only independent predictor with an odds ratio of 1.65. Our last question was, we saw this in Asia A, and what about segmental neurological recovery in all SCI and not just Asia A? So for this, we conducted a two-stage mixed effects meta-analysis to control for various covariates like age, sex, mechanism of injury, and multiple more in approximately 1,300 patients, with nearly 80% of them having a cervical level of injury. And due to the predominance of cervical injury, we also did a subgroup analysis in this population. And as you can see from the forest plot, AMD, which stands for adjusted mean difference, that the early surgery group was associated with a whole spinal level greater recovery compared to the late surgery group when considering all SCI patients. And this effect size increased to 1.25 spinal levels approximately when only looking at cervical injury patients. To conclude, these results suggest that Asia A patients have potential for significant recovery even in cases where they do not convert an Asia grade. And we have also shown a therapeutic benefit for early surgical decompression in cervical Asia A patients and the association of early surgery and segmental neurological recovery in SCI. Thank you.
Dr. Rush?
Alex, this is excellent work and really well presented. Good job. What's magic about 24 hours? If we think of compartment syndromes, we say get there as quickly as possible, take the pressure off. In spinal cord injuries, we've been stuck on this 24-hour period, and it has effects. So if I talk to my colleagues about taking someone to the OR, they say, well, I won't do it in the middle of the night because I don't want to have to mobilize a team. I'll do it tomorrow. I'll still be within 24 hours. So should we be changing our mind frame based on your perspective, saying earlier is always better, or is there something magical about 24 hours?
I think that's a great question. When I kind of read the literature, I'm sure a lot of different people, including the people that are actually practicing, have different viewpoints on this matter. But it seems like one of the factors I saw, at least in terms of research, was that this notion of ultra early surgery, so surgery within 8 hours or 12 hours, and one of the thoughts I had was if that would mean that the baseline, at least for research purposes, baseline Asia exam would be so soon. It would have to take place before the surgery, and this may, impact the accuracy of the exam in terms of research purposes as well. I see Dr. Failings is coming up. Maybe he has a better idea.
So for the orthopedic staff in the room, so Alex is a medical student. He's interested in orthopedics and he's interested in spine.
He's ahead of the curve, which is why I'm asking the question.
Okay, so there you go. And of course, there's nothing biologically magic about 24 hours. We know this, and often, I think this is kind of a numbers game, and it's kind of an early enough time frame where we've got a large enough number of patients where it'll be operated on kind of within this time frame. I think this is basically kind of what this is about. And right now there's a lot of interest in the field on what we've referred to as ultra-early surgery, and it makes biological sense. And I think, so right now there's not an agreement on what constitutes ultra-early. We've proposed in the articles that we've written that 12 hours might be considered an appropriate time frame to consider that as ultra-early surgery, and we need higher quality prospective data. But my own personal view on this is you should go in early, but then you obviously there's a lot of judgment involved in terms of the safety and the logistics and all these types of things. But I think it makes perfect sense that there's of course absolutely nothing biologically magic about 24 hours, right? It's kind of it's early, and it's what we've got is sufficient numbers at currently in 2023 to show statistical significance for.
Okay. Great discussion. Thank you, Alex. Good job. Okay, our final abstract awardee is Alison Togiesi. She is completing a PhD in the wine laboratory, and she's going to be presenting on the generation of synthetic micro-CT images of rat lumbar vertebrae through a deep convolutional generative adversarial networks. I've got it correctly.
Well, thank you very much. So vertebral metastasis occurs in up to 1/3 of cancer patients and results in a disturbed homeostasis between the bone-forming and bone-destroying cells. The rat vertebral segment shown here is riddled with osteolytic disease, leaving large voids in the vertebral body and processes. The metastatic effect on bone microdamage and morphology may contribute to increased fracture risk, which for vertebral fractures can result in pain, neurologic impairment, and a reduced quality of life. Focal and systemic treatments for metastatic disease focus on pain reduction and maintaining mechanical stability, which may target the tumor itself and affect the surrounding bone tissue. Our understanding of bone quality, considering the effects of metastatic disease and varying cancer treatments, are incomplete, which is motivating our preclinical animal studies with the goal of informing treatment planning to improve patient quality of life. Previous and ongoing studies in our lab have aimed to establish a preliminary understanding of microdamage accumulation and load to failure in osteolytic and healthy rat vertebrae following various cancer treatments, which are docetaxel, which is a chemotherapeutic, zoledronic acid, which is a bisphosphonate, and spine stereotactic body radiotherapy. This preclinical work has resulted in a large cohort of data, including micro-CT images of the spinal column. In particular, load to failure analysis involves sequential micro-CT imaging of the lumbar vertebrae as they're compression loaded until failure. These sequential images represent important information on fracture initiation and propagation that has not yet been explored. A load to failure of the L2 vertebra was previously determined with axial compressive loading of the L1 to L3 motion segment. Micro-CT images were acquired first unloaded, after 1,500 microns of displacement, and again after failure. All of these scans were inspected for fracture location, which was commonly across the pedicles and through the end plates. Bone strength and fracture location are not trivial parameters to predict, as bone composition, structure, and material properties are heterogeneous, and the distribution of damage through the bone matrix is stochastic. Thus, these sequential images provide an opportunity for understanding the effects of cancer therapies and on bone quality, especially considering these cancer treatments might affect what we're expecting to see from the bone material properties. Bone damage has previously been modeled using microfinite element models with good agreement to experimental data. However, these models require extensive setup and are computationally expensive, which limits their usage for large-scale bone quality simulations. Deep learning models present useful tools for modeling using a data-driven approach, which would allow for the bone failure process to be learned without the need for an a priori model. Generative deep learning models allow for stochastic modeling, can represent multi-scale models, and are able to model physical processes. Generative deep learning models can represent, considering the sequential images that we have from our micro-CT load to failure data, the aim of this work was to develop a generative deep learning model to create synthetic images of these fractured rat lumbar vertebrae. Generative modeling is an unsupervised machine learning task with the goal of learning the regularities or patterns in the input data such that the trained model can generate new examples that are hopefully indistinguishable from the original dataset. Generative adversarial networks, or GANs, are an approach to generative modeling that use deep learning methods and are trained using two submodels, a generator that we train to create these new examples, and a discriminator that's used during training to classify these examples as real or fake. These two models are trained together in a zero-sum game, meaning as the generator gets better at creating these fake examples, the discriminator also gets better at detecting them. So together they train each other to become better at their individual tasks. GANs have shown promise in creating realistic examples in many applications, and in particular in image-to-image translation tasks. So GANs then show useful applications in learning the representation of data between sequential images. So we may predict perhaps data from farther points in time, just given data from some earlier time point. So the model proposed for this work is a conditional GAN, or a CGAN. And this uses an additional input to the generator and discriminator, which helps inform the output for each of these models. For each iteration in a training epoch, an unloaded real micro-CT image was fed as input to the generator, which then created what it believed to be a realistic fractured representation of this same vertebra, which is why fake on this diagram here. This fake image was then fed to the discriminator, where it was classified as either real or fake with some probability. For training, also the real fractured image was sent to the discriminator for classification. The loss function for the discriminator was the average binary cross entropy of its classifications of these fake and real fractured images. So this loss basically compares the probability that the input is real with the actual class output of 0 for these fake images and 1 for the real images. So the discriminator is basically punished if it's frequently classifying these fake images as real. The generator is also trained using binary cross entropy, but instead receives praise for generating images that frequently fool the discriminator. So the generator model is following the UNet architecture, but in 3 dimensions. So this architecture was originally designed in 2 dimensions for biomedical image segmentation tasks. This contracting path basically reduces the spatial information, but increases the feature information. And the expansive path then combines both the spatial and feature information together based on up convolutions and some concatenations with higher resolution features. UNets have been trained successfully in the past with very few training images, which makes it suitable for use in our biomedical contexts where our data sets are much smaller than what's usually required to train a deep learning model. And finally, the discriminator model is a 4-layer 3D deep convolutional neural network for conditional image classification. The output of this model is a 3D array with each element representing the likelihood that that spatial region belongs to the real data set. So the training and test data sets for this model included healthy and osteolytic vertebrae from animals that had received perhaps one form of cancer treatment. However, this metadata was not included to the model as labels, and the model was only learning based on what was detectable from the micro-CT images. The training data set was augmented to improve generalization of the model, so each 3D micro-CT image was randomly rotated in 3 dimensions 20 separate times to create additional variations of these image pairs. So the training data set after augmentation was 1,364 image pairs, and the test image had 8 image pairs that were not augmented. To train this model, it was run for 1,000 epochs, which took approximately 3.5 days when running in parallel on 4 GPUs. So these are results after 1,000 epochs of training. This came from the training data set, so the model was updated based on how well it was able to recreate these examples. So the top row is the real fractured image, and the bottom row is what was output from our generator. This example has 2 fractures through the pedicles, which were predicted accurately in almost the exact same location by our CGAN on the bottom left. Some deformation of the vertebral body was also present in both the real and generated samples. In general, the model was successful in predicting fractures that were relatively small and that did not result in a large amount of change in the vertebral morphology. So in particular, these pedicle fractures were quite well captured by the model. So this example came from our test data set. So basically, these images were not fed to the model at all, so it has no idea what the actual fractured version of this image should look like, and instead it's inferring based on all the features it learned from the training images. So again, there are 2 fractures through both pedicles, which are also captured by the model in the generated case. So again, with the test data set, it's also fairly successful in predicting accurate vertebral fracture location, so long as the vertebral morphology has not drastically changed. So the CGAN is successful in generating the more common pedicle fractures, but occasionally does struggle when it comes to the less commonly seen fracture patterns. So on the left, large deformations confuse the model, and it makes it more difficult for it to predict the vertebral morphology or the fracture pattern. Vertebral fractures do occur commonly in the training data set. However, the model usually predicts these as large vertebral body deformations with small microcracks versus the large linear cracks that are seen in the real example. It is, however, notable that usually the model is not adding pedicle fractures when the real case has a vertebral body fracture. And finally, severe osteolytic disease is often not well predicted by the model. So the altered trabecular bone morphology in the unloaded images is often not translated to these fractured images. So overall, the CGAN that was developed in this work is able to generate realistic examples of fractured vertebrae. The model is able to capture vertebral morphology and add fractures. So those across the pedicles are most accurately predicted and modeled in both the training and test images, and those across the vertebral body or that cause large deformations are more challenging for the model to predict. It is, however, promising that the model is not just adding pedicle fractures to every example and does seem to know where the fracture should be, whether it can realistically add it to the image or not. This model is relatively simplistic, thus future work could consider increasing the complexity, especially of the augmentations for cases that have the less commonly seen fracture patterns. Using hybrid models that incorporate physics with the deep learning might also improve the predictive capabilities of these models, which could additionally be extended to other bony structures outside of the vertebrae. So overall, the presented model shows promising results in training a deep learning model for generating fractured vertebral images. Improvements to this model may further facilitate our understanding of how the vertebrae fracture, just from important features that have been identified from micro-CT images. Thank you very much.
Really nice work. So have you tried giving the neural network something that doesn't at all look like the spine?
No, so that we have not tried that yet. The only kind of data we've fed it so far are our preclinical models that include L1 to L3 so far.
The reason why I asked this question was I came back from the annual ISMRM conference for MR physicists and radiologists last week, and I met a colleague from Mayo Clinic. They do a lot of neuro MRI down there, and they also have AI integrated into their clinical MR scanner. So one day they decided to challenge the AI algorithm and fed in a piece of paper into the scanner, and you would not believe what it produced. It produced a brain image of a tumor with a tumor in it. So I guess one thing that people in the field are really thinking about, right, whether it's CT or MR or whatever, whenever we're using these deep learning algorithms, they're basically training on noise, right? And so you want to make sure that they are robust to things that are completely ridiculous. So just a suggestion, if you have any other body parts, put it in and see what your network generates.
No, it'd definitely be interesting, and also to try some of these are from rats, these images, so try also vertebra or bones from not rats. But yes, in terms of like it being fed noise, this is a conditional model, so we're kind of helping it at the beginning by giving it a structured image to kind of start off of. So it'd be interesting to see what it does, since we're used to giving it an initial image that it then uses to predict versus coming up with something out of nothing, exactly, yeah.
not sure if I understand this correctly or not, but presumably if you've given the model more training examples, it may be a little bit more accurate or precise. What about the flip side in terms of, when you're doing the biomechanical loading, you're assuming you're delivering whatever force is plotting in a certain way, and there may be a bit of variability in that. Does that affect things, or is it?
Yeah, it is true that we don't have like a perfect microloading process. We try to have as much of just axial loading as we can, but there are some cases where the vertebral body will slip and it's not actually pure axial loading. And those haven't been excluded from the data set at all, mostly because we have limited number of samples and I'm just trying to include as much data as I can give it. So it's not necessarily a perfect data set either way. But yeah, so there is definitely still variation and variability in the training images that we're giving the model. So yeah, ideally it would be better if the training images could be as consistent as possible, but I'm also not trying to exclude too much data, because more data would be better for the model in general.
Okay. Great, thank you.
Thanks so much.
You might as well stay up here. We'll probably have the awardees come up in order, and I guess we're getting towards the end of our SpineFEST 15th year. It's really been a terrific meeting, and it's really great to see the depth and breadth of research, education, and various initiatives being conducted in and around the city. So at this time, it's probably the best time for Michael and I, where we're able to deliver out awards to folks. And Nadia, I guess we will start off with the awardees. So in terms of the invited research trainee awardees, Dr. Lauren Hatcham, is Lauren still around? Okay, I guess maybe we'll have to keep, I guess Michael, maybe you can hand that off to
instructions
from Nadia. Okay.
Nadia. So let me see. We have, how do you want to do that? So we have the awards for the elevator pitches, hot off the press. And we have one for basic science and one for clinical. So basic science is Nayab Banjani, and clinical is Hussein Shakil. So come on up. And let me just have a look here. Okay, we'll get some pictures. There we go, Nayab and Hussein. And as they say, the check is in the mail. Come on up. Get some pictures. That's very nice. Very nice work. Nicely presented. Okay. Good. Okay. Perfect. Okay.
Oh, Dr. Hatcham, we've got the basically invited research trainee presentation, and Dr. Anne-Marie Versteg.
So Lorene and Anne-Marie. Very, very nicely presented.
Congratulations.
Congrats. Congrats. Come on, please. Get some pictures. Fantastic. Okay, great.
So basically, we have our basically best abstract presentations. So first place goes to Dr. Ali Mogadamaju.
There you go. Nicely done. Good job. Come on up here. Come on up here. Come up here. Okay, perfect.
And Mr. Alex Bach, that will be Best Abstract second place tie. And then Allison Toliesi, that would be Best Abstract second place tie.
Nice work, Allison. There you go. Thank you very much. That's for you.
Thank you so much.
Okay, and we have our fellow Best Abstract. First place will be to Dr. Aditya Raj.
Definitely a cool title. I like the title. I was the one smiling. There we go, Gary. Good job. Nicely done.
And fellow Best Abstract, second place, Nish Shrikandaraja.
It's better than a poke in the eye. There you go. As they say, come on here. There we go. Well done. Would you like this? Yeah. Okay, good. So I think that brings things to a close. So many people to thank. It's been a great day, I think. Firstly, it's been great having Professor Shaker Kurbad, give the keynote Tatter Hall lecture. Shaker, I know, would have dearly have wanted to have been here in person, but the wonders of hybrid technology, and big thanks from Albert and me to Nadia, and also to Delphine. So thanks very much for all the logistics. And many thanks to all of the faculty who gave fantastic presentations, and particularly the involvements with all the judging, and there's a lot of work that goes on in the background that's not always fully, kind of recognized, but we really appreciate it. So thanks very much, and that's great. And thanks very much to all the trainees, really fantastic presentations, and you really are kind of the heart and soul, I think, of the program. So it's really great. And we've got a number of sponsors to thank. Maybe Albert, why don't you? Right, here's our list here.
Okay, so the University Department of Surgery, Divisions of Neurosurgery and Orthopedic Surgery, Medtronic, Dupuis Synthes, Stryker, Therapeutics, Bioventus. So I appreciate all the support, and I think with this, we have our grad ceremony this evening. So that will be at the Sonesta Hotel for the fellows at 6 p.m. And many thanks again for participating today. I hope you had an enjoyable day. I wish everyone well, and we'll connect again soon. Bye for now.
Thank you, Michael. That was good. Thank you, Albert. That was good. They went quite.